Good afternoon, everybody. Uh, okay, I am going to tell you about the cardiology part of medicine. Okay, we are about to start the class. Just to emphasize before I continue with my class, that I tell every batch of dams that see, there are 19 subjects that you have to remember. There is a volume problem. Voice is not clear, I think. Voice is not clear. Okay, now it is clear. Yeah, okay. Okay, I continue. So, see, the fact is that you have to remember 19 subjects, and 19 subjects, it's all about how much you remember at the day of exam. See, when I used to prepare for my entrance exam, it used to take me 45 days to go through one revision of all 19 subjects. And by the time I used to end my revision, I used to forget the first subject. So that is also happening with you, I suppose. So the game is all about how much you remember. So just by ratification, you cannot remember the 19 subjects. So wherever possible, you can understand the thing, you should understand it. That is the first basic concept of preparing for the MCQs. So coming back to my subject of cardiology, see, cardiology is one part of medicine which you can understand and then you can remember them. If you understand it, you will never get confused. And if you try to just ratify the things, then what will happen is that two choices everybody will be able to exclude, but two choices you will come back to two choices. Yes, A or B, A or B. Yes or no? In every MCQ, we come back to two choices. Two choices are all are able to exclude. Yes or no? So the thing is how to differentiate between those two choices. So that is how can you differentiate is by knowing the fact, by understanding the fact. So that is how we have to understand the subject cardiology. In these 2 days, I'll try to teach you cardiology. I'll try to make you understand the concept, and we'll also focus on the concepts which are required for our MCQs. We won't go into details of the unnecessary topics. We'll just focus on our MCQs because that is the ultimate goal of our preparation. Right. So starting with cardiology, I generally start with very basic things, and that is a common saying that general knowledge is not common sense is not that common. So with that I start. We all know that ECG, we have all seen the ECG. So let me start with the toughest part of cardiology, that is the arrhythmias. I'll go through arrhythmias and we'll try to understand it, and then we'll try to solve MCQs also on that particular topic. Okay, let's start with arrhythmias. Okay, before going on to arrhythmias, the first thing is all about is the ECG. ECG is one thing that is used to record the electrical activity of the heart, that we all know, right? So now you try to understand that heart is a three-dimensional structure. So if heart is a, see, ECG is used to record the electrical activity of the heart, and we all know that heart is a three-dimensional structure. So if a heart is a three-dimensional structure, that means the wave of depolarization is going up, going down, going horizontal in all directions. So to record the electrical activity, you need to have electrodes in all possible plane. So basically we divide ECG electrodes into two planes. One, that is the horizontal. So, So Agra has just joined. Never mind. I just gave them the brief of the cardiology. We can continue with it. Okay. So the thing is, ECG, as I told you, it is to record the electrical activity and three-dimensional structure. We need to have electrodes in two basic planes. One is the vertical plane. When I say vertical plane, okay, this is working like this. Okay, so okay, now it is clear. Vertical plane electrodes, that is, if a person is standing, like let's suppose a patient is standing in front of you. So I just draw a hypothetical patient, and if he is standing in front of you, so this plane would be your vertical plane. You are understanding? Whereas if I take a horizontal cut section, if I take a horizontal cut section through the patient like this, that would become a horizontal plane, whereas this is your vertical plane. So when we talk about vertical plane, we have basically the limb electrodes and augmented leads. I know you all know about all this, so we'll just revise it very fast. So see, limb electrodes, when I say it is in the vertical plane, that means in the same patient that I have drawn, let me draw the limb electrodes. Lead 1 will go from, this is the right of the patient and this is the left of the patient. Okay, so lead 1 goes from right to left like this. So this arrow means this is the positive pole, this is the negative pole. Okay, so MCQ can come, that means which is the positive and which is the negative pole for lead 1. So you should always remember like this, and I'll keep drawing it. Go 60 degree down, 60 degree down, you'll have lead 2. That means this is positive, this is negative. Positive means which leg? Left leg is positive. And lead 3, when we say lead 3, it is like this. Another 60 degree down, you will have lead 3. So this is positive and this is negative. Okay, so if I remove the patient out of this plane, so let's see how the leads are looking like. Leads are looking like lead 1, lead 2, that is lead 2 and lead 3. Okay, so lead 1, 2 and lead 3. So you can always remember, if you draw this diagram, you can always remember the orientation of the leads. Lead 1, lead 2, lead 3. And see, I have always drawn two poles. One pole is the right arm for lead 1 and another pole is left arm. So these all leads are bipolar leads. We all know this, bipolar leads. Okay, so some of these are the MCQs that I'm trying to cover up, and so let's move on further. So these are only the limb leads. We have augmented leads. Augmented lead directed towards the right arm, we say it AVR. Directed towards the, sorry, AVL, this is the left arm of the patient. AVR, that is the right arm of the patient, and AVF is the foot of the patient. Okay, so you have augmented leads, limb leads, all in one plane, that is the vertical plane, and in the center this is your heart. If this is your heart, that means you are covering the heart all around the heart in the vertical plane to record its electrical activity. Okay, so this orientation is important. We'll come back to the clinical application. Let's talk about the horizontal leads. What are the leads in the horizontal plane? So let me tell you about the horizontal plane. Page. Okay, the horizontal plane, what do we call them? We call them as precordial leads. Precordial leads are in the horizontal plane. Okay, so we have V1. If this is the patient and this is your heart, and if this is your heart, that means where is V1? This is the sternum. So V1 is in the fourth intercostal space, right side. Okay, right side, fourth intercostal space. And V2 is on the fourth intercostal space on the left side. V4 is in the mid-clavicular line. Okay, so V3 is somewhere in between. V5 goes more lateral, that means the anterior axillary line in the fifth intercostal space. This is all fourth intercostal space, so this is the fifth intercostal space. And V6 goes more laterally, that is the mid axillary line. This is the anterior axillary line, this is the mid axillary line. Okay, so if you all can see V1 to V6, it covers the heart in the anterior, from the anterior side, anterior direction. Heart is behind it, posteriorly. Okay, so if I ask you, what are the leads that covers the posterior part of the heart? Is there any lead out of all these V1 to V6 that record the posterior part of the heart? No, these do not record the posterior activity of the heart. So that means we need to have additional set of leads which are known as posterior leads. These posterior leads, we describe them V7, V8 and V9. V7, V8, V9. V5, V6, they all are in the fifth intercostal space. See, V1 is in the fourth, V2 is again fourth, V4 is in the fifth, and V3 is somewhere between V2 to V4, and V5 and V6, they are again in the fifth intercostal space, anterior axillary line and the mid axillary line. Okay, so where did we leave? We left at V6 mid axillary line, so we'll continue with V7 from there. That is V7 in the posterior axillary line. Posterior axillary line. V7 is in the posterior axillary line. V6 was in the mid axillary line. This is in the anterior axillary line. Okay, all in the fifth intercostal space. V8, now you go more posterior. What is there more posterior? That is tip of the scapula. Tip of the scapula. That comes more posterior in the same intercostal space. V9, more posterior and medial. That is your paravertebral area. Paravertebral area. Okay, paravertebral area. So that means now we have covered the heart from anterior also as well as from posterior also. So these are the all precordial leads. Okay, so another feature of precordial leads is these are also known as pseudo-unipolar. Pseudo-unipolar. See, why do we call them as pseudo-unipolar is, you have kept only one pole. If you can see, V1 you have kept one electrode, V2 one electrode, V3 one electrode. Whereas in the limb leads, when I said lead 1 in limb leads, that means you are putting a right arm electrode also as well as the left arm electrode. Right? So there you are putting two electrodes. Whereas over here you are putting one electrode only. So that means these are unipolar. No, these cannot be unipolar. See, current cannot flow in between single pole. You need to have two poles. So that means if you need to have two poles, so where is the other pole of the precordial leads? And that comes as an MCQ. The second pole of the precordial leads that we call as Wilson terminal. Wilson terminal. So we call that as Wilson terminal or central terminal. Wilson terminal or central terminal. Okay. So that means precordial leads are said pseudo-unipolar, with the second terminal being the Wilson terminal or the central terminal. If you all have seen how we take the ECG, next time when you go to hospital or anywhere, you just have a look how they take an ECG. If you are taking an ECG, you put, you must have seen right arm, and left foot. They put the limb leads and the precordial leads. But an additional, there is another electrode that they put is on the right leg. What is this right leg? Right leg is nothing but grounding. Grounding, that means zero. So if somebody asks you what is the right leg lead, it is grounding of the ECG electrodes, and this is also the also acts as the Wilson terminal. So this also acts as the Wilson terminal. So if somebody asks you where is the Wilson terminal, it is the right leg electrode that acts as the Wilson terminal. Okay. So this was very briefly, I talked about the electrodes that we use in ECG. Now another important point is, see, if you see the orientation of the heart, how the heart is oriented, if you can see, your apex is in the fourth intercostal space. That means your heart anatomical position, if somebody asks you, this is another MCQ that is commonly asked. If another MCQ is that what is the anatomical position of the heart? Heart is not a midline structure. It is not a horizontal structure. So what is it? Heart is directed 45 degree lateral, 45 degree anterior. If somebody asks you what is the anatomical position of the heart, it is 45 degree anterior, 45 degree lateral. Okay, so that means if this is the midline, no, it is not a midline structure, it is neither a horizontal structure, it is directed laterally, so the axis is laterally, 45 degree lateral. Okay, and it is not a downward structure, it is anteriorly towards your chest, so that is why your apex comes close to your fifth intercostal space in the mid clavicular line. There, that is where the apex comes. Okay, so if you have understood this orientation, then let me tell you further. There is, see, your heart, if you divide your heart, that is your atria and your ventricle. Okay, your heart is like this in the chest. Now that means this is your right atrium and this is your right ventricle. Where is your left atrium and left ventricle? That would be posterior structures. So they become posterior structures. Left atrium and left ventricle, they become the posterior structures. Okay. Now if you are recording, the precordial leads are used to record the electrical activity. Okay. So these are your precordial leads to record the electrical activity. So what happens is, these precordial leads, they are more close to right ventricle than the left ventricle. But what is the dominating force? Dominating force is your LV. LV is the dominating force. So what happens is, when the depolarization is happening in right ventricle and left ventricle both simultaneously, what happens? It is the left ventricle forces which are recorded in the precordial leads. And RV forces, they are masked, or they are hidden within the LV forces. So if you want to record RV activity alone, how will you record the RV activity alone? By putting additional precordial leads. What are these additional precordial leads? These are known as right-sided precordial leads. These are known as right-sided precordial leads. So where are they located? So they are the mirror image of the left-sided leads. So what is the mirror image? V1 of the left side, we started from the right fourth intercostal space. Yes or no? Okay. So V1 of the right-sided lead, we will start in the fourth intercostal space, but on the left side. So because it is a mirror image. So V1 right, V2 right, V4 right would be in the mid-clavicular line on the in the fifth intercostal space on the right side rather than on the left side. Okay, so now this is how we put the right-sided leads. Now out of these, which one is important to record the right RV activity? It is the V3R and V4R. V3R and the V4R. So these two leads, they are used to record the RV activity. Okay, so let's move on further. Once we have understood these ECG electrodes, let's talk about the localization of MI. That comes as an MCQ in your this thing. So I'll show you a diagram. See, it is the foundation batch who is there. I think you know what is the ECG electrodes and all that. You must have seen the electrodes at least. So let's talk about it again. Okay, never mind. We'll talk about it again. See, when we talk about a normal electrodes, precordial electrodes, till V1 to V6, till posterior leads, it was clear? Till posterior leads, it was clear. That is the Agroha College. Okay, we'll repeat again. Okay, we'll repeat again. See, very simple it is. You have the heart being a three-dimensional structure. Okay, so three-dimensional structure means, that means you have vertical activity also, horizontal electrical activity also, vertical, horizontal, in all possible directions you will have ventricular depolarization. Yes or no? Okay, so now what is there is that if you want to record the electrical activity, you need to have electrodes all over around the heart to record the electrical activity. Okay, so how do we put the ECG electrodes? There are two basic electrodes. One is the vertical plane. That means you cut the person vertically like this. Okay, so you have a vertical plane across the heart and you have a horizontal plane across the heart. You are understanding this much? Okay, so if you are understanding this much, now let's talk about the leads. As far as leads are concerned, see, when we talk about the vertical electrodes means, that means you will have limb leads that we put. I explain you what are the limb leads. So let's see. I'll draw the final diagram that we had seen. So okay, let me draw the diagram for the limb leads. Limb leads, I told you limb leads would be lead 1, lead 2, that is 60 degrees down, lead 3. Okay, so these are the three leads. These are the limb leads that we call. Okay, so arrow means this is the positive pole and opposite is the negative pole. Okay, so that means you can see this notepad. Sefai, can you see the notepad? So that is what it is. Okay, so this is your notepad only. I am drawing the diagram on the notepad. Okay, so these are the three limb leads. So if you remember this diagram, you can easily remember what are your positive pole, what are your negative pole. Heart is in the center of this diagram. So what is happening is, your any electrical activity which is directed, let's suppose it is directed towards the right arm. So if it is directed towards the right arm of the patient, it will be recorded in the opposite direction of the lead 2. Okay, if any electrical activity is directed towards the left arm of the patient, it will be in the opposite side of the lead 3. If it is directed downward towards the left leg, let's suppose, so it will be it will be recorded in the lead 2 positive direction. Okay, so this is how depolarization would be recorded in the vertical plane. Okay, so similarly you have augmented leads also, because these limb leads are not sufficient to record all the activity. So we had augmented leads which we call as AVL, that is the left arm of the patient, not yours. Yours would be opposite. Right arm of the patient and foot of the patient. Okay. See, augmented leads, when we say augmented leads, they don't have additional pole, they have only single pole, and that is the positive pole. And the negative pole, when we talk about the augmented leads, their negative pole is same as that of Wilson terminal. Their negative pole is same as Wilson terminal. Okay. So let's move on further. So this was all about the vertical leads. Let's talk about the horizontal leads. Horizontal leads, they cover the heart from anterior of the chest. They will cover from V4. See, if you can see me there, that is in the V1 would be in the fourth intercostal space, right, on the right side. V2 would be on the fourth intercostal space on the left side. Okay, so this is how your heart is covered by your precordial leads. So let me draw the again diagram and let me show you. So it will be more clear when we move on further. I'll show you the diagram, then that would be more clear. See, this is your heart and this is your precordial leads, V1, V2, V4, V5, V6. Okay, they all cover the heart anteriorly. To cover the heart posteriorly, what do we have? We have V7, V8 and V9. Okay. See, whenever the depolarization, in which direction it is moving, that is the positive direction. Okay, so that means if the depolarization is moving towards, let's suppose it is moving towards your left foot, so that means it would be positive in which lead? It would be positive in lead 2. So the direction of depolarization will decide, yeah, lead 2. So it would be the direction of depolarization that would decide the positivity or negativity in a particular lead. Okay, so now the precordial leads, I have already told you, these are pseudo unipolar because you are putting a single electrode, and now to have a you cannot have a current flowing between one electrode, so you need to have another electrode which we call as Wilson terminal, that we have already discussed. So okay, so I think the things are now clear. Things will become gradually more clear. Let me show you one diagram, and now we'll come back to your applied part, which on which the MCQ comes, and that is important to understand also. Uh, so let me show you one of the diagram, very beautiful diagram, and okay. Can you see this screen? Okay, so we cannot do the okay, yeah, we cannot start the PowerPoint. PowerPoint. PowerPoint करना है. Slide show. नहीं ऐसे पावर पॉइंट करना था ना. आप वो तो इकट्ठे ही आ रहा है हाँ? जैसे अपने आप पूरा नहीं, मुझे इसमें ऐसे जैसे ये पावर पॉइंट होता है ना, ऐसे ऐसे एक एक करके है. स्लाइड शो नहीं चलेगा क्या? अगर तो देखो, अगर ऐसे होगा तो ये तो पूरी स्लाइड आ गई, और नहीं तो अगर सपोज करो इफ आई ओपन द पावर पॉइंट देन एक एक पॉइंट आता है बीच में ऐसे, जैसे मैं ऐसे दिखाना चाह रहे हैं। हाँ, वो एक काम करिए ना, स्लाइड को ऊपर नीचे रखिए ना, एक एक पेज पे, तो ऐसे तो यहाँ पे चालू करने का नहीं पता नहीं। चलो कोई बात नहीं, ओके, तो अभी ओके, नेवर माइंड, ओके ओके। सो can you see this diagram? Okay, can you see this diagram? Okay, this is the, if you have the limb leads 2 3 AVF, you go back to and see your diagram that I draw. 2 3 AVF, they all were positive pole was downward, yes or no? So if the positive pole was downward, that means they are looking at the heart from below. So which surface of the heart is represented in these 2 3 AVF leads? That means it is the diaphragmatic surface. Diaphragmatic surface is nothing but the inferior surface. Okay, so inferior surface is represented in 2 3 AVF. So if you have an MI that involves this surface, this will be seen, ECG changes will occur in which leads? 2 3 AVF. Okay, so that means these are inferior wall MI is represented in 2 3 AVF. Now let's go on to 1 and AVL. 1 AVL, I told you, one is directed like this from right side to left side of the patient. So that means one is positive on this side. AVL means left arm of the patient. So again, positive on the left side. So left shoulder is positive in these two leads, and this is looking at the heart from the lateral aspect. Okay, this is looking at the heart from the lateral aspect. So which area of the heart is represented? That means the lateral surface of the left ventricle. So lateral surface of the left ventricle, that means which MI? Lateral wall MI. Okay, we'll maintain the speed also. This is just a bit too slightly tough part, so I'll just cover it up. And okay, so let's move on further. V3, V4. V4 I told you is in the mid-clavicular line. It is in the fifth intercostal space. That is where your apex is. When you do the examination, that is where the apex is. So V3, V4 will cover your heart. That is the apical part of the heart. And apical part of the heart, and also it is anteriorly located. So which MI? Anteroapical MI. Okay. V1, V2 comes more medially. So more medially, that means this is the apex of the heart. If you come more medially, that means this is the septal part of the LV. See, RV is not recorded. I already told you RV will not be recorded because LV is the dominating force. So LV will cover up the RV. So it's all about LV portion of MI that we are talking about. We are not talking about RV MI. So V1, V2, this will record which type of MI? It will record the anteroseptal MI. That is, if you remove the RV, what is there below? It is the septum, interventricular septum. So it is the anteroseptal MI. Now again coming back to V5, V6. V5, V6 is nothing but it is a lateral leads. So again they record the lateral wall MI just like 1 and AVL. Okay, so this is how. Okay, never mind, it's the same thing. Don't worry about foundation or regular batch. Starting is slightly more difficult, so this is a concept you should understand. So it's okay, we'll cover up the syllabus. No, don't worry about the syllabus. Okay, so let's move on. So you have understood, I think. Concentrate on the subject rather than foundation or regular. Okay, so just concentrate on this. V1, V2, V3, V4. Okay, this is how we localize the MI. So let's move on and let me show you an ECG. Okay, ST elevation. This is the ST elevation that you can see. ST elevation. So that means this ST elevation represents the MI. Okay, now if you can see the leads 2 3 AVF, they have ST elevation, so that means it is an inferior wall MI. Okay, so another thing is that if you can look at the leads, number of leads given, if you can look at the number of leads given, V8, V9, this is also having ST elevation. There is an ST elevation in V8, V9 also. So that means which leads are these? These are the posterior leads we discuss. So posterior leads means which MI? Posterior wall MI. Another set of lead given is V4R. That means V4R means, that means which part of the heart is represented in V4R? It is the right. It is the right ventricle that is highlighted in V4R. So V4R will be representing RVMI. So in this ECG you can see the inferior wall MI, posterior wall MI and RVMI. Okay. So this is how we localize the MI, and this is all what are the MCQs they ask you. Okay, we'll localize further in the atherosclerosis and MI chapter. We'll talk about it again regarding which artery is involved. Okay, that means we have to go more sophisticated then. Okay, next let's talk about the another topic very rapidly, just to discuss about the important MCQs that are covered. That is, see, when we talk about the conduction, normal conduction system of the heart, that you all know, must have done in your physiology all by now. I think this is the last or second last class, so already has been discussed. So this is the, see, this is the sinus node. Where is the sinus node located? This is an important MCQ. Sinus node is located at the junction of the SVC with the RA. So see what is there in this diagram. What is there in this diagram? That is, I have opened the anterior wall of the heart. So what is there underlying it? I have opened the RA, opened the RV. So this is the interventricular septum and this is the interatrial septum. Okay. And behind this septum would be your LV. This would be LV behind it. And behind this interatrial septum would be your LA. Okay. So now let's talk about it. Anatomy very briefly. So sinus node is located at the junction of your SVC with RA. Okay. The pulse of depolarization starts from sinus node, depolarizes the whole of atrium, right atrium, and it also goes to left atrium, through which bundle there is a specialized conduction tissue that conducts it to left atrium, and that bundle is known as Bachmann's bundle. BACHMANS, Bachmann's bundle. I'll write it down later on. Okay. It is the Bachmann's bundle that carries depolarization to the left atrium. Bachmann's bundle. Okay. Once the depolarization reaches the AV node, where is the AV node? AV node is also in the right atrium. Okay. This is the right atrium where the AV node is, and there is a special anatomical structure over here on which MCQ comes. What is that MCQ? Cox triangle. What is the Cox triangle? What is the Cox triangle? Let me write and then show you. What is the Cox triangle? Okay. See, this is your Bachmann's bundle. What is Bachmann's bundle? Bachmann's bundle. Okay, so this is what carries to LA, the depolarization wave, and another structure is known as Cox triangle. This must have been done in your anatomy also, and this important MCQ comes on this Cox triangle. So how the Cox triangle is made, if you remember the diagram that I had just shown, so in this what happens is you have a triangle which looks like this. This is within the RA. This is the RA that is there. Okay. So what happens is on the apex of this Cox triangle is your AV node. This is important from both practical point of view as well as from the MCQ point of view. Now what are the boundaries? So if you talk about the boundaries, see, first of all you understand the orientation. This is the RA. So where is your RV? RV is like this. Okay, now you tell me which is an anterior structure, ventricle or the atrium? Ventricle is the anterior structure. That is why your apex comes close to your chest wall. Fifth intercostal space, mid clavicular line is your apex. So that means posterior structure is your atrium, anterior structure is your ventricle. Okay, heart is directed like this, coming anteriorly from the chest wall. Okay, so now if this is the anterior, so which is the anterior boundary? This is the anterior boundary. And this anterior boundary, if you remember, this is the junction between RA and RV. That is which valve? This is the tricuspid valve. So tricuspid valve would form your anterior boundary. Okay, now your posterior wall. Posterior wall is divided into superior part of the posterior wall or the inferior part of the posterior wall. So now if I say inferior part, this is nothing but coronary sinus opening. See, coronary sinus drains into the right atrium. You remember your anatomy. Coronary sinus is nothing but the venous drainage of the heart that drains into your right atrium. Okay, so that opens in the right atrium at this location. So this forms the postero-inferior boundary of the Cox triangle. And what is the superior boundary of the Cox triangle? This is nothing but a specialized tissue that acts as a tendon of Todaro. Tendon of Todaro. So postero-superior boundary is tendon of Todaro, inferior boundary is your coronary sinus os, and anterior boundary is your tricuspid valve. Okay, so that is all about the Cox triangle. And what is the applied part is that your AV node lies at the apex. Okay, now let's move on further. We were talking about the conduction system of the heart. So now from AV node, your wave of depolarization goes to the ventricle. Okay, so if I have to draw the wave of depolarization, I again draw. Let's suppose this is the sinus node, this goes to AV node, then it goes to the ventricle and then divides into two bundles, right bundle and the left bundle. Okay. Now you tell me, what is the electrical link between atria and ventricle? What is the connecting link? Is it the AV node, or is it Purkinje fibers, bundle of His, or all of the above? So the answer, see, you all must be thinking AV node. No, it is not the AV node. AV node is within the right atrium. Okay, so we cannot have both. It is the bundle of His. From AV node, bundle of His goes to the left ventricle like this, and then divides into the two branches, bundle branches. Okay, so it is the His which is the connecting link. Okay, so now you have all understood all this, and from the bundle branches starts your Purkinje fibers that ultimately depolarizes the entire myocardium. Okay, so another MCQ that comes is depolarization wave goes from endocardium to epicardium. Okay, endocardium to epicardium. And from where the wave of repolarization goes? Yes, repolarization, direction of repolarization. Repolarization, it is epicardium to endocardium. Okay, okay. So that is all about the MCQs that I have covered over here. Let's talk about the ECG. How they are represented in the ECG. That you all know, atrial depolarization. Atrial depolarization is P wave. Ventricle depolarization is QRS. So what is new about it? Just few concepts that I want to tell you. Let me draw the ECG. This is the P wave. Then you have a QRS. And then you have a T wave. Okay. So P wave represents your atrial depolarization that you all know. After atrial depolarization, if you see your conduction system, what do we have? We have AV nodal conduction and the bundle of His conduction. Okay, then starts your ventricle depolarization. So that means between the P wave and the QRS, that is atrial and ventricle depolarization, you have two structures. AV node and bundle of his, that comprises this horizontal part of the ECG. Okay, and this horizontal part of the ECG, we call it as which segment, which interval? This is known as PR segment. PR segment. This horizontal part. Okay, this we call as PR segment, and PR segment represents, that means, conduction through AV node and bundle of phase. Okay, next, PR segment plus P wave, what will it make together? They will together make what is known as PR interval. PR interval. Okay, so you have PR segment, PR interval. So do not confuse between segment and interval. These two are different things. Okay, last point about ECG and conduction system I like to discuss is your QT interval. See, QT starts from Q, onset of Q, and to the T end of the T wave. So this is your QT interval. Okay, so QT interval is very, very important when we talk about arrhythmias. We'll come back to it during ventricular tachycardia. But QT interval, it varies with your heart rate. QT interval varies with your heart rate. So that means, and how it varies, it is inversely related. Your heart rate, as the heart rate decreases, QT interval increases. Okay, so if you need to have a cutoff, for a cutoff you need to have a standard value. So if a person is at a heart rate of 70, he will have different QT. If a person is of 90 heart rate, he will have different QT interval. So you need to standardize it. How do you standardize it? Is by using a Bazet's formula. This we call it as Bazet's formula. There are 2-3 formulas, but the most commonly used is your Bazet's formula. And how do we do this? Is QT divided by RR square root. This gives you your QTC, corrected QT interval. Corrected QT interval. See, there is an interval known as QT. So if you have a QT interval, that varies with your heart rate. So to standardize, that should be independent of the heart rate, so that a patient comes with any heart rate. If the corrected QT interval is above a particular limit, you will say it to be abnormal QT. See, what is that is you are not understanding. QT interval you have not understood. You know what is QT interval, Agra? See, PR interval we have already discussed. P plus PR segment will make your PR interval. Now what is your QT? Next interval that I want to discuss is your QT interval. What is this QT interval? Starting from the Q wave to the end of your T wave, that will be your QT interval. Okay, nothing special, but just an interval, and so this is a QT interval, but it is important from the MCQ point of view also, as well as practically also. So when we say QT interval, this is the QT interval. It keeps, no, not RR interval, QT interval. See, QT is the starting of Q to the end of T wave. RR would be R between two R's, that is this R and the another R of the another QRS. That would be your RR interval. Okay, see, RR would be, if you have this is one R of the QRS, next when next QRS comes, that is the another R. So these are the two RR intervals. That will be your RR interval. Okay, you mean what is there in RR interval means in this formula. Okay, so RR interval means this 2R interval between the two consecutive R's, that is your RR interval. So that means QT under root by RR interval means that interval between two consecutive R waves, that will give you corrected QT interval. Corrected QT interval. Okay, and this corrected QT interval, we have to calculate in all individuals to see whether QT is prolonged or not prolonged. Okay, now comes your MCQ. What are the causes of prolonged QT? Causes of prolonged QT. Okay, prolonged QT means, that means all hypo conditions. What are the hypo conditions? Hypo means hypokalemia. Write down hypokalemia. This is the first thing that comes to your mind. Prolonged QT. Okay, and now cut it. Except for hypokalemia, hypokalemia does not cause prolonged QT. This is the commonly asked MCQ. Rest of the hypomagnesemia, hypocalcemia, they all cause prolonged QT, but not hypokalemia. You should write it down, and then you write it down as hypokalemia. Write it down and then cut it, so that you always remember it. Okay, what is the normal QT interval? 440 millisecond is your normal QT. 440 millisecond. Anything above 440 we call it as prolonged QT. Okay, so next is your, there are drugs that cause prolonged QT. Drugs causing prolonged QT. That must have been done in your pharmacology. Just to tell you few drugs that causes prolonged QT. One of them is cisapride. What is cisapride? It is a prokinetic drug. Nowadays almost banned because it used to cause ventricular arrhythmias because of the prolonged QT. So then is all antiarrhythmics are prolonged QT. All antiarrhythmics except which group? Class 1B. Except class 1B. This is another MCQ that is asked. Class 1B drug. What are the class 1B drugs that do not prolong QT? What are these? See, these are, just make mnemonics for whenever you have a list of things to be remembered. Try to make a mnemonic out of it. What is the mnemonic? What I used to remember is that LMP, last menstrual period, that we call it as in gynae. So what is that? Lignocaine, maxillatine, and phenytoin. So these are the three drugs that comes under class 1B. Not flecainide. Flecainide is class 1C. We'll come back to it. Okay. So that is all about prolonged QT. So I think ECG, some idea is there about ECG. We have covered the MCQ portions also. Okay, let's move on to now the electrolytes effect and the drug effects on the ECG. Electrolytes and drug effect. This is very important from MCQ point of view. And see, tokenide, flecainide, they are, if you can see, they both sound similar. When they are sounding similar, flecainide, tokenide, that means they are of the same group. Same group means they are not 1B, 1C drug. Okay, let's move on further. The next thing is electrolytes effect on ECG. Electrolytes. This is the last part, then we will move on to arrhythmias. Electrolytes. See, we have already discussed about hypocalcemia. Just simple ones will finish first. Hypocalcemia prolongs QT. Hypercalcemia, opposite. Hypercalcemia, what will it do? Shortens QT. Okay, what are the other causes of shortened QT? See, terfenadine is not a antiarrhythmic. Okay, so let's move on. Hypercalcemia shortens QT. What are the other causes of short QT? Short QT interval. Causes of short QT interval. Hyperkalemia, hyperthermia, digoxin effect, hypercalcemia, hyperkalemia, hyperthermia, digoxin effect. They all shortens QT. This comes as an MCQ. Okay. Next, what are the most important electrolytes that we have to discuss today is your potassium. Last year also MCQ came. So let's talk about short QT is not below 440. Short QT means less than 300. Class 1B does not shortens QT. It does not have an effect on QT. Okay. And short QT, if you talk about definition, it is 300 millisecond. We call it as shortened QT. Okay. These cutoffs actually values are not important for you from the MCQ point of view. Anyhow, if you want to know, I'll tell you. Okay. Let's move on. Potassium. Potassium. Let's talk about hyperkalemia. Hyperkalemia, when I say hyperkalemia, that means more potassium. See, when you have more potassium, potassium is responsible for which part of your action potential? Depolarization or repolarization? So it is repolarization. Okay. So it is involved in repolarization. That means what? That means you have more potassium, so means more forces of repolarization, more strong forces of repolarization. So that means hyperkalemia, the earliest change in hyperkalemia would be, what it would be? What are the repolarization forces in ECG? In the ECG, when you see the repolarization, it starts from ST segment. So you have ST segment elevation, shortens the QT. QT is short, and T wave would be tall T waves. So what is happening? Your repolarization forces are prominent. Tall T, short QT. That means repolarization is fast. So that means short QT and ST elevation. All these are part of your earliest changes in hyperkalemia. So tall T wave, there is a specific term for this tall T wave which we call as tented T wave. Tented T wave. What is this tented T wave? Why do we call it? Well, because the base is narrow. This base is narrow. Okay. There would be another tall T wave when we talk about MI. I'll tell you about tall T wave. There the base is broad. We'll keep revising all this. This will keep repeating. Okay, in the next of the lecture, see, the things that we are doing now will keep coming again and again in my lecture. So you understand it for a moment. Even if you don't remember it, it's okay. When we revise it again, you will remember it for a longer period. Okay. So just don't get confused. Keep writing it and keep understanding at this moment. Okay. Now what are the when the severe hyperkalemia occurs, what are the changes then occurs? See, during severe hyperkalemia, everything becomes slow in the heart. Everything becomes slow. So that means everything becomes slow means P wave becomes decreased in amplitude. Decreased P wave amplitude. PR gets prolonged. QRS becomes broad. Okay. So severe hyperkalemia means everything getting slowed down in the heart. Okay. So next, last is, this is your P getting decrease in amplitude, prolonged PR, broad QRS. T would remain like this, tall T wave, and this is your ECG complex. Now, With time, what happens is, if it is too severe, P wave may not be visible at all. It may be a total flat line. You may not be able to see the P wave. So absent P wave, absent P wave. Now there is no P wave, only QRS, and then you have a tall T wave also, and this keeps repeating. This complex keeps repeating, and you have, okay, so this complex keeps repeating. Over here again one more complex I draw, and this is your T wave. So this complex keeps repeating like this. So this looks like a wave. Can you see this looks like a wave? This is the wave that we used to study in your physics. That is, when if you drop a stone in a pond, you see the wave on the surface of the water surface. That is the same kind of wave that you see. This we call as sine wave pattern. Sine wave pattern. See, these things are very, very common in when you talk about commonly seen in practical, in your clinical practice, and very often I have seen repeatedly people misdiagnosing it to be VT, ventricular tachycardia, but this is a slow sine wave that is going on. Okay, and what would be the management for hyperkalemia? Yes, already I think it's already done. First step in hyperkalemia management. First step in the hyperkalemia management is, that means you have to immediately stabilize your, calcium. You are right. Calcium is the first step in management of any arrhythmia because of hyperkalemia. Not insulin, not restriction, nothing. Calcium. See, first stabilize the membrane. Calcium is used to stabilize the membrane, not to treat the hyperkalemia, but it is used to stabilize the membrane, so that for the moment you get time to reduce the potassium. Calcium will immediately stabilize the membrane, prevent all these sine wave patterns, arrhythmias. It will prevent all these things, and then for half an hour it will give you see, magnesium you cannot use. You have to use calcium. Being a magnesium, it has its own side effects if you use it too much. But magnesium is nowhere written that you can use magnesium. I don't know about the magnesium, because if you look at the concept of giving calcium behind during hyperkalemia, it is to stabilize the membrane by giving a positive ion. And as far as magnesium is concerned, I don't know if that can be given, because both are 2 plus ion, both have positive charge. If theoretically you ask me, it can be given, but I don't know. Okay, because it's not given in the books that magnesium can be given, and I have not given in the practical life also. Okay, let's talk about the next part. Another interesting feature in hyperkalemia is your sinoventricular rhythm. What is sinoventricular rhythm? Sinoventricular rhythm, when we talk about, see, we'll come to VT. When I say VT, this sine wave looks like a VT. I told you everybody misdiagnosed it as VT. Yes, so that means it looks like a ventricular rhythm. But we know that this is what type of rhythm? This is a sinus rhythm with hyperkalemia effect. See, if there is no ECG changes and there is no patient is not affected by hyperkalemia, you need not give calcium. Calcium is just to buy time so that you can correct your hyperkalemia. Okay, so that is an emergency treatment, calcium, and it gives you half an hour. Calcium effect remains for half an hour. For over half an hour, if you can reduce the potassium, that will take care of your hyperkalemia. Okay, So if there are no ECG changes, nothing is there, patient is stable, you just have hyperkalemia present, then you have to manage hyperkalemia by giving whatever is the cause for hyperkalemia. Let's suppose it is a chronic kidney disease, acidosis, severe acidosis. That means correcting the acidosis will correct the hyperkalemia. So you have to give bicarbonate as the treatment. Okay, if there is another cause for hyperkalemia not relating to acidosis, then you can give insulin as well as glucose. If you ask me which is the best and fastest method of reducing potassium, that is your insulin and glucose. That is the fastest method of reducing potassium. Okay, so there has been a lot of confusion also regarding whether calcium to be given or not. It is not to be given if there are no ECG changes. Okay. Right, sine wave pattern. See, there is nothing in sine wave pattern. If you go back to your this original complex, if I keep repeating this complex in the subsequent ECG complexes, if I keep drawing this complex again and again, this will look like a wave. This will look like a wave. ECG, whole ECG will look like a wave. Yes, this wave we call as sine wave pattern. Okay. Now, let's move on to further. That is the last point about hyperkalemia, is that hyperkalemia you can see all kinds of blocks. Just write it down for a moment. We'll come to when we talk about arrhythmia, you'll be better aware of what are the blocks. It can cause complete heart block, it can cause bundle branch block, right bundle, left bundle, it can cause all kinds of blocks. Okay. Let's move on to the next electrolyte, that is hypokalemia. Hypokalemia. Now, again I tell you, see, the management of hyperkalemia, no need to get confused. There are two managements in hyperkalemia. One is your stabilizing the membrane so that patient is stabilized. Okay, first you have to stabilize the patient. Second is you reduce the potassium. Okay, so these are the two management. See, that is because if you ask me why it stops in diastole, diastole is nothing but after the repolarization. After the repolarization, that means the you have too much of positive charge. See, that will, I think, will confuse the rest of the students. I think that particular answer I'll give you separately. Whosoever has asked me regarding diastole in hyperkalemia, okay, I'll come back to it later on. Regarding this management, sinoventricular rhythm, you'll understand once we do the arrhythmias. I'll tell you why it looks like sinoventricular rhythm. I'll come back to it again. And as far as your this thing is concerned, management, I think it's already clear that first you have to stabilize the patient by giving calcium if patient is unstable. If there is no ECG changes, nothing is there, that means patient is stable. That means you need not give calcium. Why to give unnecessarily calcium? Then you have to concentrate yourself in reducing the potassium. Okay, so that is the management of hyperkalemia. Okay, next we move on to hypokalemia. No, it's not the same thing, it's different, but I'll come back to it. Just wait for the next topic to be covered. I'll come back to the sinoventricular rhythm. Okay, hypokalemia. See, again, if I tell you potassium is required for repolarization, that means if in hyperkalemia all your repolarization waves were more prominent, ST was elevated, QT was shortened, and your T was more elevated. So what will happen in hypokalemia? Opposite. What is the opposite of that? ST depression, T wave inversion. That means T wave amplitude decreases T wave, and it may become inverted also. Okay, and you have a new wave appearing, that is your U wave appearance. Okay, so that these are the three basic things that occurs with hypokalemia. And with severe hyperkalemia, PR interval also prolongs, uh, but there are no blocks. As such, no blocks occurs in case of hypokalemia. Only you see are the arrhythmias that are present in hypokalemia. Arrhythmias you see in hypokalemia. Okay. So that is all about hypokalemia. Let's move on to the drug effect. One of the drug that is very commonly used is digoxin, that we have a low therapeutic index. So digoxin toxicity and digoxin effect. See, digoxin effect, if you all know what is the mechanism of digoxin effect, I need not go into details, but digoxin by itself causes electrolyte changes in the cell. In case of hypokalemia, there are no changes in QRS. Okay. So what happens is your T wave is not visible. So that is why what happens, you have a PQRST. So sometimes what happens, T wave is not visible in your hypokalemia. So what will happen? You will have a complex like this. No T wave. Okay. And then there would be a U wave. So some people take it, if you have to measure QT interval, they will take this U as the T wave and they will say QT is prolonged, but that is wrong thing. So it is not a QT, but what interval it is this? This is QU interval actually. Okay. So that is why this comes as a commonly asked MCQ, that QT interval, what happens to QT interval in your hypokalemia? QT remains normal. It is your QU that is prolonged. Okay, let's come to digoxin, which is the most common toxicity. Which system is most commonly involved in digoxin toxicity? It is the GIT system. See, all the MCQs regarding digoxin are important. So GI system is the most commonly involved system for nausea is the most common complaint, decreased appetite, nausea. Okay, second most common system is your CVS, and for CVS, which is the most common toxicity, arrhythmia that it causes, that is the ventricular premature complexes, VPC. We call it as ventricular premature complexes. I'll just after this I'll explain you what are these VPCs. You just write down. Okay. So there is a pulse that is we call as bigeminy. Pulsus bigeminy. I'll discuss this also. Pulsus bigeminy is the most common toxicity if somebody asks you in arrhythmia. Okay. Now digoxin toxicity can cause all kinds of arrhythmias except is important because it can cause all arrhythmia, that is parasystole, something known as parasystole. No need to go into details, but you can the other term is that came as an MCQ, biventricular pulse, that is biventricular pulse. And definitely Mysore and Kolhapur, they are right that Mobitz type 2 block does not occur with digoxin toxicity. Mobitz type 2 block. Mobitz type 2 block. We'll discuss what are these blocks after this. Mobitz type 2 block does not occur. Okay. So this was all about the toxicity. Now when I say digoxin, when you give digoxin, just digoxin itself has certain effect on the ECG. What is this effect of digoxin on the ECG? See, what happens is, if you know what is the effect of digoxin, how it acts, it reduces the potassium in the cell. Intracellular potassium is reduced. Okay, I won't go into details, just I tell you that it inhibits sodium potassium ATPase, and that is responsible to push the sodium out and potassium in. So if this thing is blocked, what will happen? Potassium is not pushed in. That means intracellularly potassium is reduced. So all the changes that in hypokalemia you see in ECG would be the same you see in digoxin toxicity also. Okay, So what are the ECG changes that you see in hypokalemia? The same thing you see in digoxin toxicity: ST depression, T wave inversion, U wave appearance. Okay, and in addition to this, there is a vagomimetic effect. That is right, vagomimetic effect. What is vagomimetic effect? That it increases the vagal tone, so thereby causing what? PR interval prolongation plus sinus bradycardia. Sinus bradycardia. So what is the U wave? See, it is nothing but the delayed depolarization, delayed. What is the U wave? U wave is, okay, the effect of digoxin, let me repeat again. It's all about hypokalemia changes plus vagomimetic effects, if you want to remember it in short. Okay. Now somebody asked me what is the U wave, how the U wave appears. U wave appears because of the delayed repolarization of mid-myocardial cells. Delayed repolarization of mid-myocardial cells. Okay. See, T wave and U wave you can differentiate on the ECG. Basically, U wave is more symmetrical, whereas if you see the T wave, it's more steeper in onset, whereas more gradual in downslope. Okay, so these are the minor changes that is how we see in case of this thing. Okay, so now coming back to your digoxin toxicity, or digoxin effect on the ECG. So these are the, basically you have hypokalemia plus vagomimetic. Now within the hypokalemia there are certain sign. What one of the sign is inverted check sign. What is this inverted check sign? This is nothing but ST depression looks like this, like a tick, inverted check. Okay, if I have to draw an ECG with an inverted check sign, how it would look like? This is the QRS, and then what would happen to the ECG? ECG ST would be like this. So this is what is inverted check sign. Okay. This is your inverted check sign. Now, see, in case of hypokalemia, it is only the potassium that is reducing. Whereas in case of your in case of your digoxin toxicity, it's not just the potassium that is changed. What else is changed? What is the primary effect of digoxin on the heart? You increase the contractility. How do you increase the contractility in digoxin? You increase the contractility because you increase the calcium levels in the heart. Yes or no? Yes. So that is what I am giving you the answer. You have yourself answered me. If your calcium increases, what will happen to your QT? Intracellular. It will decrease. Therefore, digoxin is the only condition where you will have QT reduction with sinus bradycardia. Okay, these all are complex things. I don't expect you to remember all this, but just because you are asking me question, and that is why I'm answering you, but these things are not required at your level. So you can have shortened QT only seen in case of digoxin effect, not in case of hypokalemia. Okay. So that finishes your drug effect and your electrolyte effect on ECG. Let's move on further. Let's talk about something about arrhythmias. Let's come to the medicine part, huh? Okay. Okay, that is also correct. There are so many doubts in so many people. Basically, you are asking questions out of your curiosity. The thing is, we can ask you questions. You just keep your questions with you, and we can have them in the end. Okay, because the other people are finding it difficult to understand things because uh, they all become confused. So keep your questions with you. I'll answer all your questions in the end of the topic. Okay. So that will smoothen the class also. Okay. So new question that you want to ask. If you want to ask clarification within the same topic, within the something you have not understood, I can repeat it, that you can ask me. Okay. But do not ask me new questions which are not relevant at this point of the time. Okay. You keep them in the end, we will discuss. Okay. So let's move on further. What are the arrhythmias? When I say arrhythmias, see, arrhythmias, we include both brady as well as tachyarrhythmias. So brady and tachyarrhythmias. Brady means heart rate less than 60, tachy means more than 100. Okay, so let's discuss about the bradyarrhythmias first. See, we have already discussed that sinus node is there, and then you have an AV node. Another MCQ commonly asked is, what are the velocities of conduction velocity in these tissues? Which one has the maximum conduction velocity? The maximum conduction velocity is that of your Purkinje fibers, that is 4 meters per second. I think it's audible to all. Okay, so let's talk about the bradyarrhythmias first. When we talk about bradyarrhythmias, I was talking about the conduction velocity. Which tissue has the maximum conduction velocity? This is the commonly asked MCQ. Purkinje fibers is your... You are able to listen or not? Rotak, can you listen? Okay, so just forget it. What thing you want me to repeat? I just started with arrhythmias. Arrhythmias, there are two types, brady and tachyarrhythmias. Brady is less than 60, tachy is more than 100. When we talk about, let's talk about bradyarrhythmias first, and then we will talk about the tachyarrhythmias. So bradyarrhythmias, when I say bradyarrhythmias, see what is happening is, you have... no, it does not matter. It's a very basically, I am going very slow as well as basic things I am telling you. We won't discuss excess deviation, that is not required for the MCQ portion. So we have to focus on MCQ part, not just the cardiology in general. Okay, so now let's talk about the bradyarrhythmias. We have the sinus node, AV node. I talk about the conduction system. Just this is the basic conduction system. Again, I am drawing bundle of phase. This is your right bundle as well as the left bundle. Okay, so by now you are familiar with this diagram. So sinus node is your basic pacemaker. So what happens is, One of the type of bradyarrhythmia can be because if your sinus node is disease, so what will happen is that uh, sinus node is disease, so that will result in sinus node dysfunction. Sinus node dysfunction. This is sinus node dysfunction. Okay, so sinus node dysfunction. And what will happen in the ECG? If you see the ECG would be okay. We will repeat and take care of foundation but separately. You just continue with your class, and whatever you can understand, you try to understand now. We can repeat the topic again. Okay, so don't worry about it. Sinus node dysfunction, these all are basic things I am telling you. I have not started even your medicine part till now. Okay, so let's talk about it. Sinus node dysfunction, the first part of bradyarrhythmia is because of the sinus node dysfunction. What would be the ECG like? See, in the sinus node dysfunction, the pulse is not starting from sinus node, or it is starting with delay, or it is slowly starting. So what will happen is your heart rate reduces to less than 60. But once the wave of depolation starts from sinus node, it will all be normal. Yes or no? So all your intervals would be normal, QRS would be normal, everything would be normal. Okay, so that is what heart rate would be less than 60, but your ECG complex, each complex would be normal. So if somebody asks you what happens to PR interval in case of sinus node dysfunction, it would be normal. Okay, so that means the number of complexes per minute will reduce, but each complex would be normal. Okay, second cause of bradycardia is, if you have a problem over here, AV node and bundle office, AV node and bundle office. So what will happen is that now your impulse from sinus node, it is either getting delayed in getting conducted to ventricles, or they are getting blocked over here. Okay, so this would be the second cause of bradycardia. This we will call as AV node dysfunction. AV node dysfunction. So now in this case, what will happen? In AV node dysfunction, your PR interval would be prolonged. That is, this is the PR segment part of PR interval that is prolonged. PR segment part of PR interval would be prolonged. I already discussed what is PR segment, what is P wave, this is the P wave. So together you call it as PR interval. So your PR interval would be prolonged, or this would be affected in case of AV node dysfunction. Now we classify AV node dysfunction into three varieties, that is first degree, second degree, third degree, depending on the severity. So what is first degree, second degree and third degree? Second and third degree. What is it? First degree, second degree and third degree. First degree means all P's, that means all atrial depolarization, they are getting conducted to ventricle, but with the delay. So that means what is happening? All P's are getting conducted to ventricle, but with the delay. So with prolonged PR interval. Okay, just first we discuss what are first, second, third, then we'll come back to the details. Second is when not all P's get conducted. That means, let's suppose there are 4 P's. Out of 4 P's, only 3 get conducted to QRS, to the ventricle. So that means 1 gets blocked. So there is a 4:3 conduction. Okay, so this is the second degree AV block. Third degree AV block means no P gets conducted to QRS. No P gets conducted to QRS. Okay, so that means severity is increasing from first degree to third degree. Okay, so now let's talk about details on which the MCQ comes. Let's talk about first degree AV block. First degree AV block, PR interval, I already told you, PR interval is prolonged. And another important feature is it is constant. In a particular, see what is the normal PR interval, that reminds me, what is the normal PR interval in an individual? 120 to 200 millisecond. I'm calling it millisecond. You can also say 0.12 to 0.2 seconds. One and the same thing. It's one and the same thing. Okay. So 0.12 to 0.2 seconds is your normal PR interval. So in case of first degree AV block, PR interval would be prolonged, that is more than 200 millisecond, but it would be constant. All QRS in a particular individual, let's suppose it is a 300 millisecond, then all QRS would have 300 PR interval. Okay, so that means it is constant and prolonged. And number of atrial depolarization is equal to number of ventricle depolarization. That means number of P would be equal to number of QRS. Okay, in the ECG. Now let's talk about the second degree AV block. What is second degree AV block? Not all P's are getting conducted to QRS, some gets blocked. So this is a two types of second degree AV block. Mobitz type 1 and Mobitz type 2. Okay, so when we say Mobitz type 1, when I say Mobitz type 1 means that what will happen is, let me draw an ECG and explain you what will happen with Mobitz type 1. See, initially you will have a normal PR, then you have a QRST, then what will happen? PR will get prolonged, then subsequently further prolonged, PR gets further prolonged, and ultimately what will happen? One P will not conduct at all. This P will not conduct at all. So after this another P will come, that will get conducted. Okay, so this is what is your Mobitz type 1. That means what is happening? Happening is PR interval is gradually prolonging till one of the P does not conduct to QRS. Okay, so that means PR interval is constant or is it variable? PR interval is variable. So you have a variable PR interval that gradually increases until one P does not conduct to QRS. This is also known as Wenke-Bach phenomena. Wenke-Bach phenomena. Wenke-Bach phenomena. Okay, Mobitz type 2. Now in case of Mobitz type 2, let's see what is Mobitz type 2. Let me draw an ECG and explain you what is Mobitz type 2. In this, PR interval is constant. So what will happen is, you have a, let's suppose this is an individual with constant PR. So you will have a constant PR, but suddenly what will happen? One P does not conduct at all, followed by again constant PR. Okay, so how it is different? So how it is different from the Mobitz type 1? It is different from Mobitz type 1 because Mobitz type 1 PR gradually prolongs, whereas in Mobitz type 2 you can see PR is constant and suddenly one P will not conduct to QRS. Okay, so in both Mobitz type 1 and type 2, what is happening is one of the P's are not getting conducted. Therefore, this is known as second degree AV block. So both comes under second degree AV block, but the pattern is different. Okay, now let's move on to the third thing, that is complete heart block or the third degree AV block. Complete heart block or third degree AV block. Okay. Yeah, both can show 4:3. It is not a fixed pattern. You can have 3:2 pattern. You can have 4:3 pattern. The point is number of P's will be more than number of QRS. One of the P's will not get conducted to your QRS. That is the important thing. Okay, you can have 5:3 also. That means 5 P's but 3 QRS. 2 are not getting conducted. So it can vary. Okay, now in case of complete heart block, what is happening? You have P, 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 no QRS. So now what will happen? See, if you have a complete heart block, no P is getting conducted to QRS, can this person survive? This person cannot survive. Okay, so similarly, see, God has given us lot of reservoir in our body. So what happens is whenever one thing stops functioning, there is some reserve in the body to take care of the emergency situation. It is just like an inverter in your house. What happens when your light goes, electricity goes? What happens? Your inverter starts. Okay, so now there are certain problems with the inverter also. Let's see what are the problems with the inverter and what are the problems with this complete heart block. What happens is when your P stops, P does not conduct to QRS. There is no QRS complex. So what will happen is your ventricle starts to produce its own depolarization. So let's see if this is your heart now. Okay, so now there is a block over here. No P is getting conducted to QRS. So what will happen is ventricle will start its own depolarization. Okay, so so what will happen is ventricle will start its own depolarization. So now once the ventricle starts its depolarization, so this is what we call as escape rhythm. See, you have to use the terms that are commonly used in your MCQ. So I'll keep introducing you with the terms. Escape rhythm. That means what is happening is P is not getting conducted to QRS, but the patient has to survive. So what will happen is one of the focus in the ventricle, it will start to produce depolarization on its own. So once it starts depolarization on its own, so what will happen is this is known as escape rhythm. So what is the features of escape rhythm? One would be that the rate would be very slow. Rate is very slow. So rate of QRS would be very slow. What is the rate of QRS in this? Let's suppose 40 or 50 beats per minute. Okay, so this is just like inverter. I told you, when your inverter works, the voltage is low as compared to your natural electricity supply. Similarly, when your this thing escape rhythm works, the rate would be very slow as compared to your normal heart rate. Okay, so that means now what will happen? Ventricle is getting depolarized by its own wave of depolarization. Atria is getting depolarized by the wave of depolarization coming from the sinus node. Yes or no? So that means you have two different waves of depolarization and affecting atria and ventricle separately. Right? So atrial rate would be decided by your sinus node rate. So let's suppose your sinus node is normal, so rate is your 70 beats per minute. So your atrial rate would be 70 beats per minute. Okay, whereas your ventricle escape rhythm, let's suppose, is 35 beats per minute. So what will happen? Your ventricle complex that will come, it will be at the rate of 35 beats per minute. 35 beats. So for every 2 beats you will have one escape rhythm, QRS. Yes. So now you can yourself see what is the association between atria and ventricle. Is there any association? Both have their independent rates. One is at 70, one is at 35. Will there any association remain between the atria and ventricle? See, Purkinje fiber is nothing but your ventricle, na? So that is what it is. You will have Purkinje fiber taking over means ventricle escape rhythm. It's the same thing. Okay. So you have both atria depolarizing at its own rate, ventricle depolarizing at its own rate. Both are independent of each other. We call it as AV dissociation. So I wanted to introduce this term, AV dissociation, and one of the a physical finding of AV dissociation on physical examination is what in JVP? What do you see in JVP if you have AV dissociation? That is Cannon wave. What is Cannon wave? That I'll explain you in JVP also, but let me just, those who know about JVP, just to revise you, see in JVP you see an A wave, that is because of the atrial contraction. When atria contracts you have an A wave. Okay, so what happens is when your atria contracts against the closed AV valve, that is when your atria is contracting and ventricle is also contracting, because there is no association between the two. Though, so when your atria is contracting, ventricle is also contracting, what will happen? AV valve will be closed. So atrial blood will not go into ventricle, resulting in a back pressure, increase in the back pressure that we will see as a large A wave in the JVP. That is known as a Cannon wave. Okay. So if somebody has asked me, is it a regular Cannon wave? No, it is not a regular Cannon wave. We will talk about electromechanical dissociation. That is a different issue. Okay. So not here. When I'll come to your this thing, DC shock and all that, will come to electromechanical dissociation. This is not electromechanical dissociation. This is just that both atria and ventricle, they have their own depolarization. Okay. And junctional rhythm is different. Okay, we'll come to junctional rhythm different. Okay. So that is what is Cannon wave. You will see Cannon wave in junctional rhythm also, but that is a different issue. Okay, I won't confuse the students with that. So that is all about the blocks, first degree, second degree, third degree AV block. Okay, so I think the things are clear. Now let's move on further. What is the management of the arrhythmia? What is the management of this bradyarrhythmia? What is the management? So just to tell you that we do what is known as a pacemaker implantation. See, in cardiology, it's not just the theory that you have to understand. You should also understand the procedures that we do in cardiology. Because just 1 year back, there was an MCQ that they asked that a patient has been implanted with a pacemaker and now he comes after 3 days with some problem in the pacemaker. So what is the best screening tool for pacemaker? So if to answer such questions, you should know how do we implant the pacemaker. Just a rough idea. If you have seen a cath lab, have you ever seen a cath lab? Yeah, chest x-ray, you are right. Bilaspur, that is absolutely right. But for rest of the students, let me tell you, how do we put a pacemaker or how do we do all the procedures in cardiology? That is under a fluoroscopy. And what is fluoroscopy? That is under fluoroscopy. Let me write it down. We do it under fluoroscopy. So what is fluoroscopy? It is just like ortho C-arm. You have seen the C-arm in the ortho operation theater. It is just like X-ray machine. Okay, we call it as fluoroscopy. So let me show you one of the pacemaker we had implanted, and I'll just to so that you have an idea what is there in the pacemaker. Okay, so can you see this pacemaker? See, what we do is, this is from the right side we had implanted. This is the right subclavian vein. We go into the subclavian vein, it goes through SVC, it goes into RA, from RA it goes into RV. Can you see the apex over here of the lead? This is the lead that is placed in the RV apex. So now what will happen is that a battery is connected to this lead. This battery will keep on giving small current to the heart so that the heart rate is maintained. Okay, so this is what we do in case of any bradyarrhythmia. Bradyarrhythmia, basic problem with the heart is that his heart rate is low. Rest everything is fine. Heart muscle is fine, everything is fine. The only problem is that heart rate is low. So to increase the heart rate, we will give current at a fixed rate. We will fix the rate. This we can fix the rate. So that means if you can see, this whole thing is, this is just nothing but an X-ray. This is nothing but an X-ray. The whole image is nothing but an X-ray. So this is your battery and this is your lead that is connected, and this goes over here into the RV. Okay, so what we will do is we will take an X-ray at the time when we implant. We take an X-ray. Now if a patient comes to us after 3 days with this pacemaker not functioning properly, so what will happen? They will come to us that some problem is there with the pacemaker. So how do we know that there is a problem with the pacemaker? The first screening tool is just simple X-ray. You do an X-ray. So what will happen is, if this lead which is coming to this RV apex, you can see the RV apex, this lead, bright lead. If this lead is not here but it is hanging in the RA, let's suppose it is hanging in the RA. So what will happen? That means this lead has got dislodged from the RV into the RA. That is why this pacemaker is not functioning properly. So this we can just diagnose by getting an X-ray done. No need for CT scan, no need for MRI, nothing. Okay, only simple test you need to do is your X-ray. So this is the, I'm using the marker. Can you see the marker? This is your so I don't know how to use this marker. This is the marker I'm using. Marker. Okay, never mind. Just the simple thing you can remember is, from this you can see the battery, you can see the lead. This is simple thing. We put a lead in the RV and we connect it to battery. That you can understand without the pointer also. Okay, I'll take this pointer. So this is your battery. Okay, so this, from this battery, this lead goes out, and this is where the apex is, RV apex, where the lead, you can see the lead. Can you see the lead now? ले लेते हैं. Okay, so this is your RV lead tip. Okay, so that is how you have your management of bradyarrhythmias with the pacemaker. Okay, so okay, we'll take a break. There is no problem in taking the break. The issue is, if there is any problem, you can ask me question. If you have what is the time? It's 3:52. So let's see what is the, shall we take break or not break? Most of them are saying no, no, no. So we go by the majority, and we'll just finish off 1 or 2 topics and then we'll take the break. Okay, we'll take around, okay, we'll finish 1 or 2 topics, then we'll take the break. Okay, let's move on. I'll repeat in the break. Okay, whatever doubts you have, you can ask me during the break. Okay, let's move on the next topic, that is your tachyarrhythmias. Okay, you want okay, I'll continue with the tachyarrhythmias. No, drugs are temporary management. Ultimate management is your pacemaker. And if somebody asks you what all drugs you can give, then you should know that sympathomimetic drugs you will give, not parasympathomimetic. Okay, just to increase the heart rate. Yeah, you are right. Atropine you can give, that is vagolytic. Vagolytic drug you can give, or sympathomimetic drug. Okay, what are the sympathomimetic drug? One of the drug very commonly used is isoprenaline. Okay, this is isoprenaline. Single chamber pacemaker, dobutamine you can also increase the heart rate, no problem. Okay, this is about the single chamber pacemaker. Don't get confused about the what variety of pacemakers. I won't go into details. Just I wanted to tell you how we put a pacemaker, that is more important. Okay, so that MCQ, anytime this kind of MCQ comes, you should know what is the screening tool for this pacemaker. Another important point is, if you see the single chamber, the okay, I won't go into detail. Next, okay, let's talk about the tachyarrhythmias. Tachyarrhythmias. See, the most important tachyarrhythmia that we have to discuss, number first is your WPW. I'll discuss WPW and atrial fibrillation, and then we will take the break. Okay, these are the two most commonly asked tachyarrhythmias MCQ. Okay, what is WPW? What is WPW? Let's talk about WPW. See, normal conduction, I again draw sinus node, AV node, bundle of phase, right bundle and left bundle. So you have this normal conduction system in the body. Okay, what happens is this generates a P wave, atrial depolarization generates a P wave. Let's draw it. Okay, after that there is a slow conduction system, that is AV node. AV node is slow conduction system. Therefore, there is a gap which is known as PR segment. Okay, subsequently followed by your ventricle depolarization, QRS. Okay, this is clear. Now let's talk about the WPW patient. In this patient, you have what you have? Accessory pathway. So let's talk about accessory pathway. What is the accessory pathway? That means there is another connecting link between the atria and ventricle, other than your bundle of phase and AV node. Other than bundle of phase and AV node. Yeah, aberrant pathway. You also call it as aberrant pathway. So now what will happen is, wave of depolarization starting from sinus node, it will spread into the atria. Yes or no? Okay. Now, to reach the ventricle, there are two ways. One is through the aberrant pathway, other is through the AV node in this individual. Okay. Now, if I say aberrant pathway conducts very fast, whereas your AV node conducts very slowly. So what do you think? It will go through which pathway? It will go through your aberrant pathway fast. So therefore, your ventricle depolarization will start from your aberrant pathway. Yes. So what will happen? Now, P wave was generated by atrial depolarization. Now what happened? This PR segment which was generated by the AV node, now this AV node is not this wave of depolarization is not going through AV node, but it is going through aberrant pathway very fast. It is very fast. So what will happen to your PR segment? PR segment will decrease, so resulting in your short PR. This will result in short PR interval. So first change in ECG would be your short PR interval. Okay. Next, your QRS starts to form from the aberrant pathway conduction. Yes or no? Okay. Now the wave of depolarization reaches the ventricle through the aberrant pathway and starts spreading in the ventricle like this. Okay. Now when it starts spreading in the ventricle like this, what do you think? Is this a normal spread or is it an abnormal spread? Normal or abnormal? This is an abnormal spread. So abnormal spread means, that means what would be the velocity of spread? It would be slow or fast? Slow or fast? It would be slow. Absolutely right. So that means this wave of depolarization that reaches through the aberrant pathway into the ventricle. It reaches early, fast, it reaches very fast. But when it reaches the ventricle, it starts to spread. That spread is very slow. Understood? So you can write one line that this aberrant pathway conduction, it reaches early ventricle. It reaches ventricle early, but spreads slowly. But spreads slowly. Okay, so this will sum up what is happening over here. So what will happen is this wave of depolarization will spread slowly. So what will happen? The QRS that would be formed by this wave of depolarization would be broad QRS. Why? Because it is slowly spreading. Slowly spreading means it is taking more time to depolarize the ventricle. Therefore, QRS represents ventricle depolarization. So it will also be broad QRS. Okay. So that means you have second part is slurred QRS. Slurred QRS or delta wave. Delta wave or delta wave. ब्रेक लेनी है वो तो सब कह रहे हैं कि कोई ब्रेक नहीं आगरा के साथ ओके एक मिनट बाद ये टॉपिक के बाद ले लेते हैं Okay, so this is your short PR interval, slurred QRS or delta wave, and okay, you are understanding the point. See, the wave of depolarization that reaches the ventricle through aberrant pathway, it will reach very fast. Why? Because the conduction is very fast. But ventricle depolarization is very slow. So that means QRS would be broad QRS that it will generate. Okay, so that is why you have a slurred QRS or delta wave. Okay, see, the spread will remain endo to epi. It will remain endo to epi, but the only thing is that it is spreading in the opposite direction, whereas the normal conduction is like this, whereas this is the opposite conduction. Okay, so you have a slurred delta or QRS that would be your broad QRS. So this is your delta wave. See, what will happen is your first part of your QRS, this would be broad and this would form a delta wave, and then like this. This is your QRS that you will see in case of WPW. You can call it fusion beat also, that it is because what happens is the ultimately your wave of depolarization through AV node also reaches the ventricle. So both wave of depolarization depolarizes the ventricle, resulting in one of the fusion beat. So you are right, Mumbai, that it is a fusion beat. Okay, so what is happening is in case of aberrant conduction, it will result its own QRS that would be spreading like this, whereas your AV node is spreading in this direction. So you will have a aberrant QRS that is a fusion beat, as Bombay says. So you have a slurred QRS that you will see. Short PR, slurred QRS, these are the features of WPW. Okay. So let's finish off the management of WPW. The lowest one is your ECG in WPW, short PR and slurred QRS. This is your slurring. Okay. Short PR, slurring. These are the two features. Ultimately, you have to remember these two features only. Okay. So, okay, let's start the class. Okay. There is a WPW that we were talking about. WPW. See, the two ECG signs that you will see in WPW, I again repeat, that is, see, what I said in the beginning was that the Purkinje fibers is the okay, we'll come back to it. See, after the topic, this break was because of the technical error. You just keep writing your questions and we will discuss at the end of the topic. Okay. So before the break, I'll give you 10 minutes and we will discuss all the topics, whatever you have the queries. Okay. So we'll continue with the class. The two ECG changes that we see in WPW, I again repeat, it is the short PR interval and delta wave and delta wave. Delta wave. See, important thing about delta wave is it is an early delta wave. So what are the causes of late delta wave? What are the causes of late delta wave? Late delta wave, this comes as an MCQ. Number 1, Osborn wave. What are the causes of Osborn wave? Seen in which condition? Osborn wave. Hypothermia. Another is your epsilon wave. Seen in which condition? ARVD. What is ARVD? Arrhythmogenic right ventricle dysplasia. Okay. So you have Osborn wave, epsilon wave. These are the two causes of late delta wave. So whenever MCQ comes, it should be early delta in WPW. It should not be late delta. You should always be clear of these two facts. Okay. Now let's talk about the management of WPW, which is generally the question comes on the management. So see, when we talk about the management, there are two types of presentations in WPW. Number 1 presentation is that patient absolutely is normal. He is getting an ECG done during his routine investigation, and that ECG he finds that there is a WPW on the ECG. So that means you are finding WPW on routine screening. Okay, this would be your first presentation. Second presentation is, we will come back to it, we'll discuss in detail. Second presentation would be when the patient presents to you with some kind of arrhythmia. Okay, so these are the two presentations. So let's talk about first the routine screening. So if a patient comes to you with the routine screening, see, generally this is very common these days, because what happens is that the more you this is a common fact that the more you earn, you are more health conscious. Why? Because you fear for death. Yes or no? So that is why nowadays every now and then the individuals, they undergo what is known as health checkup. So they undergo health checkups, and that results in what is known as routine screening, and you find an ECG with WPW pattern. Okay. Now this individual comes to you, to the cardiologist. So now the first thing that you want to know before you start management is whether this individual is symptomatic or asymptomatic. So let's see. If the individual is symptomatic or asymptomatic. Okay. So how do you differentiate whether patient is symptomatic or asymptomatic? That means now he has come with you with WPW pattern on the ECG. So now you have to, only way you can differentiate is by taking a proper history. So that means on history, how do you differentiate whether this individual had any arrhythmia in the past or not? Right? So a patient of WPW coming to you on routine screening, you want to differentiate between symptomatic and asymptomatic on the basis of the history. So history, how do you classify on, how do you differentiate on history? See, there are 2 points that will tell you that the patient had a palpitation, whether this was arrhythmic palpitation. Yeah, you are right, history of palpitation. But palpitation you can have even with sinus tachycardia, you will have palpitation. Yes or no? So see, whenever you are anxious, you are going for exams, your heartbeat is fast, you can feel your palpitation. Yes? So that is also a palpitation. That is very common. So how do you differentiate between the palpitation of sinus tachycardia and the palpitation of arrhythmia? So that is how you will differentiate. So the point to differentiate are, number 1, sudden onset, sudden offset. This will be seen in arrhythmia. Sudden onset and sudden offset. What does it mean? See, if you see any patient, whenever you start running, what happens? Your heartbeat increases. Initially, if let's suppose your heartbeat was 70, when you run, your heartbeat increases to 90. When you more run, what will happen? Your heartbeat increases to 110. If you more continue to run, your heartbeat will increase to 130. So this increase is gradual. Yes. And when you start taking rest, again your heart rate will settle down gradually. Whereas in your arrhythmia, what happens? Patient is relaxing, sitting comfortably, suddenly his heartbeat increases to 200 from baseline 70. So that means sudden onset. So whenever in the history they give sudden onset, that means it is an arrhythmia. Okay, this was the MCQ asked in AIIMS. So this point is very, very important. Second point is, there will be a situation for sinus tachycardia to happen. Situation means like you are running, you are doing exercise, you have exams. So that means they all are causes of palpitation because of sinus tachycardia. But if patient is just relaxing, sleeping, if at that time he has palpitation, that would always be arrhythmic. You are understanding? So situation is very, very important. So these 2 points together will help you whether the palpitation is arrhythmic or it is non-arrhythmic, sinus tachycardia. Okay, so when this patient comes to you on routine screening who has been found to have WPW, you ask whether you have palpitations any time in the past. He says, yes sir, I had palpitation, lasted for 5 minutes, and after 5 minutes it all became normal. Just for 5 minutes it came and it all became normal then. So that means it started and within 5 minutes it all became normal. So what is this? This means there was an arrhythmic episode, but it was so short, it lasted only for 5 minutes. Okay, so you will classify this individual as symptomatic. Okay, so what is the management of symptomatic patient who was found to have WPW on routine screening? Okay, the management is RF ablation. RF ablation. Now the other portion. If the patient says, no sir, I never had this kind of palpitation, I always, it's always situational, so that means it's all sinus tachycardia, it's never arrhythmia. So that means patient is asymptomatic. Okay, he is asymptomatic but he has WPW on the ECG. So what is the management? See, till now, what used to be the management was reassurance. In old MCQs, if you see, the answer is reassurance. Okay, but now what happens is, now these days what is happening is that these days your patients are becoming more intelligent. Yes or no? So that is why your MCQs are also changing. Now just reassurance is not enough. See, when in real life patient comes to you, what they do is they go through the topic in the net. They go through the topic in the net and they come with all the information that they acquire through the net. So sometimes I've seen patients with the questionnaire in their hand and they just keep ticking that, oh, doctor has asked you the right question or not. Huh? So these days, just by saying reassurance, if you say the patient, okay, reassurance, that is the management of asymptomatic WPW, that means the patient will think he doesn't know anything about WPW. So the management has changed. Now we do what is known as risk stratification. Okay, so what is risk stratification? Risk stratification means that what is the chance that this individual in the future may develop some life-threatening arrhythmia. Okay, so we have to classify the individuals into low risk and high risk. Low risk and high risk. So if I say a patient is low risk, that means the chance of developing life-threatening arrhythmia in the future is very low. So you can just reassure the patient and say, okay, nothing is to be done, you can go home. Okay, but if I say that, oh, no, this individual has a high risk of developing life-threatening arrhythmia, that means you have to manage this WPW, otherwise this patient can die suddenly one day. Right? So what is the management for high risk individual? High risk individual, the management would be RF ablation. Okay, so now the question comes, how do we do the risk stratification? This was the MCQ asked in AIMS also. So how do you do the risk stratification? Risk stratification, first thing you should remember, it has to be a non-invasive test. Non-invasive test. What are the non-invasive tests that we use for risk stratification? Number one, TMT. What is TMT? TMT is treadmill test. If you have been or you may have gone to gym or some health club, then there you must have seen your TMT, treadmill test. So treadmill, there you ask the patient to run and you keep monitoring the ECG. Okay, so there, that is how you do the TMT. Second is your 24-hour Holter. What is 24-hour Holter? 24-hour Holter means that you connect the ECG to the patient and there is a cordless device that keeps recording the ECG, and you connect it to the patient and send the patient home. Patient does all his routine activities at home, and meanwhile the machine is recording his ECG, and after that the patient comes back and you take out the Holter and you analyze the ECG. Okay, this is what is 24-hour Holter. Okay, so if you understand 24-hour Holter and TMT, then these two tests are used for risk stratification. Okay, so nowadays they will ask you, asymptomatic individual on routine screening found to have WPW, what is the management? So management will include risk stratification, they can give directly or they can give TMT or 24-hour Holter separately. And then if it is low risk or high risk, accordingly you have to manage. Okay, so that is the management if the patient comes to you with asymptomatic WPW on routine screening. Second is the patient comes to you with arrhythmia. Now, see, the patient already is having arrhythmia. So that means there are two things you have to see. One thing is that you have to manage the arrhythmia first. And second is you have to take care of the WPW so that arrhythmia does not occur again. Okay, so now managing the arrhythmia means first is the arrhythmia management. So now let's talk about the arrhythmia. These individuals can have two types of arrhythmia. Number one, it is the PSVT they can have, or they can have atrial fibrillation. Atrial fibrillation they can have. Okay, now 80% of the times it is PSVT and just 8 to 10% is your atrial fibrillation incidence. So you have seen PSVT management in your emergency posting, those who are of the regular batch. If yes, what is the management? The management of PSVT is, the first thing is carotid sinus massage. Carotid sinus massage is the first management. And second management, if still patient continues to have PSVT, would be your adenosine. Okay, so adenosine, it is given not as an infusion but as a bolus. Bolus is given IV. You should always remember. Why? Because it has a short half-life. T-half is very short. That is around 10 to 20 seconds is the T-half. So you have to be very, you have to give it as very rapidly as a bolus. Okay. And another is, if patient has contraindication for adenosine. What are the contraindications for adenosine? Contraindication for adenosine. That means patient is bronchial asthma. So in these conditions, what would be the drug of choice? Drug of choice would be verapamil. Verapamil is the drug of choice. Okay. Next, atrial fibrillation. Keep your questions for the end. Atrial fibrillation. Now, in atrial fibrillation, see what is happening in atrial fibrillation. You need to understand the concept. See, when I talk about atrial fibrillation, let's talk about, let me take another page and I'll explain you. See, in a normal individual, you have a sinus node, AV node, bundle of hairs, right bundle and left bundle. Okay, this is a normal individual. Okay, now what is happening is atrial fibrillation. What happens in atrial fibrillation? Your atrial rate goes up to 400, 500, yes or no? Okay, so your atrial rates are very, very high in atrial fibrillation. So in a normal individual, not all these atrial depolarization gets conducted to ventricle. There is an upper limit of the AV node. So that is a defense mechanism for you God has given. So what is the upper limit of AV node? Yes, this is given in your Genong. 230 beats per minute is the upper limit of the AV node. Okay, so that means ventricle rate cannot go up above more than 230 in a normal individual. That is why atrial fibrillation is not life-threatening in a normal individual. Okay, now let's talk about an individual with WPW. Now what will happen? If this individual develops atrial fibrillation, now he has a pathway which has no upper limit. So now all atrial depolarizations can conduct through pathway to the ventricle. Yes or no? So if atrial rate is 400, let's suppose to 500, what would be your ventricle rate now? Ventricle rate can be 400 to 500. Right? So that means atrial fibrillation in WPW can be life-threatening. Can be life-threatening. Right? So now, see, all these individuals, when they come to you, any arrhythmia patient comes to you with palpitation. So that means the palpitation, why the patient has palpitation? Is it because of the atrial depolarization or is it because of the ventricular rate? It is because of the ventricular rate that the patient has palpitation. So whenever you have to treat palpitation in any individual of arrhythmia, you have to control the ventricular rate. So now let's talk about this individual of WPW with atrial fibrillation. Now, how can I control the ventricular rate? You can control the ventricular rate in this individual by blocking the accessory pathway. Yes or no? If I block the accessory pathway, this wave will not conduct to the ventricle. But there is another pathway also present. What is that? AV node. If I do not block simultaneously AV node, what will happen? Waves will not go through the pathway, but they will go through the AV node. So that means these individuals require both accessory pathway and AV nodal blockage. Okay, so now the drugs that block, first of all, the drugs that block the AV node. Let's talk about the drugs that block the AV node. What are the drugs that block the AV node? There is a mnemonic, that is A, B, C, D. Okay, see, what are the drugs that block the AV? In case of WPW with atrial fibrillation patient, if you have to control the ventricular rate, you have to block both the pathways, normal AV node also as well as the pathway also. Okay, but same drug rarely acts on both the pathway. Different drugs act on two different things. So number one, AV nodal blocking drugs. These are the A, B, C, D. What are the A, B, C, D? A for adenosine, B for beta blocker, C for calcium channel blocker, D for digoxin. Okay, see, if you don't block AV node, what will happen? All the waves that are coming through from the atrium, 400 to 500 is the rate. Now they can go to ventricle either through the pathway or through the AV node. Now if you block the only pathway, what will happen? The waves will then go through the AV node. Yes or no? Though the upper limit will be 230, but still ventricle rate would be high. Yes or no? You have to bring the ventricle rate to the normal level. Normal level is your 70, 80 is your normal level. So patient of palpitation, if you block only the accessory pathway, he will still continue to have palpitation. Why? Because now they are going through the AV node, if not through the pathway. So you have to block both the things. So for blocking the AV node, you have the drugs A, B, C, D. For blocking the pathway, what are the drugs? Class 1A and 1C drugs. So what are these class 1A drugs? What are these 1A drugs? Class 1A drugs are, again, mnemonic. See, always form mnemonics. This queen needs cocaine. This queen needs cocaine. So what is this? Disopyramide, quinidine, procainamide. Okay, so class 1A drug that blocks your accessory pathway. So drug of choice is procainamide. Drug of choice is, out of all these three, drug of choice is procainamide. Okay, so the answer would be, if somebody asks you WPW with atrial fibrillation, what is the management? Management includes procainamide plus one of the AV nodal blocking drugs. Okay, but most of the times I've seen your MCQs, they do not give the AV nodal blocking drugs. So plus they will not give procainamide plus AV nodal blocking drugs. So procainamide isolated will also be your drug of choice. Okay, but you will never give what? Isolated AV nodal blocking drug. If you block only the AV node, what will happen? All the waves will go through the accessory pathway. So what will happen? Your ventricle rate will further increase. So you have to block both the pathways. Okay, you cannot block one of them only. So the commonly asked question is, they will give you all the AV nodal blocking drugs plus procainamide. So procainamide would be your answer. Okay, so this is the management of atrial fibrillation with WPW. Okay, let's move on further. See, when we say blockage of AV node does not mean that it will completely block the AV node. It will slow down the rates. Okay. Now, what about 1C drug? I'll come to 1C drug also in the next topic. In what are class 1C drugs, I'll tell you. Now, next topic is your atrial fibrillation. LMP is for your class 1C drugs. Class 1B drugs, sorry, not class 1C. Okay. Okay, atrial fibrillation. Let's talk about atrial fibrillation. First of all, I'll discuss atrial fibrillation with atrial flutter. So, do one thing in your page, draw 3 columns like this, and let's talk about atrial fibrillation and flutter, how they are different. Okay. Then we'll go on to discuss the management and rest of the things. Okay, atrial fibrillation, what happens? See, your atria is depolarizing at the rate of 350 to 550. This is your atrial rate in atrial fibrillation. Okay, so you can understand, if somebody has to depolarize 350 times in a minute, so rapid are the depolarization waves. So what you will see in the ECG, you will see just P's like this. They are so fast that they are occurring at 350 times per minute. So no organized P wave you will see. You will only see just fibrillatory waves. We call it as fibrillatory waves. Okay. On the other hand, in atrial flutter, what happens? In atrial flutter, your atrial rate is 250 to 350 beats per minute. So 250 to 350 is slightly lower side. So that means you will be able to see a organized P wave like this. They will be fast, but they will be organized. Well-defined P wave would be present. Okay. So you have a well-defined P wave, and this appears in the ECG as sawtooth appearance. What do you mean by sawtooth appearance? See, if you have seen a saw that is used to cut the wood and all, so the cutting edge of the saw is like this, cutting edge. So that is why we call it as sawtooth appearance. Okay, this is about the atrial rate. Let's talk about what will happen to the ventricle rate in case of patient of atrial fibrillation. Now, ventricle rates in case of atrial fibrillation, it would be irregularly irregular. What happens? P will get conducted to QRS irregularly, sometimes very fast, sometimes very slow. So ventricle rate would be irregularly irregular. Okay, so these are not regularly appearing ventricle QRS. Now what will happen in flutter? In flutter, there is a fixed block. Fixed block is just like we saw second degree heart block. What happens in case of flutter? You can see there will be a 2:1 block, 3:1 block like this. There will be a fixed block. So what will happen? Let's suppose there is a 2:1 block. So after every 2P you will have a QRS. After every 2P you will have a QRS. 2P QRS, 2P QRS, 2P QRS, 2P QRS. Right? So what will happen to the QRS? Is it irregular? No, it is regular. Okay. So you have a regular QRS. Why? Because the block is fixed 2:1 and you have a well-defined P wave in flutter. Okay. So you have understood what is the difference between atrial fibrillation and atrial flutter. Now further, the MCQ came. One of the MCQ was, I will discuss that MCQ. See, to control the ventricular rate in all these patients, to control the ventricular rate, what do you give? Which drug you will give? You will give AV nodal blocking drugs. AV nodal blocking drugs. Yes. So what are these drugs? A, B, C, D. Okay. You have given this patient one of the AV nodal blocking drug to control the ventricular rate, that is to control the palpitation. Now, out of all these 4 drugs, which one is the most toxic drug? Digoxin is your most toxic drug. So often you see patient coming to you with atrial fibrillation and atrial flutter on digoxin with digoxin toxicity. So now let's see what will happen if you have a digoxin toxicity in a patient of atrial fibrillation or atrial flutter. What will happen? What will happen? Just try to understand little bit and then we will. Okay, now what will happen? See, digoxin toxicity in atrial fibrillation, it will cause complete AV block. So this is your sinus node, AV node, bundle of his, right bundle and left bundle. Digoxin toxicity causes complete heart block. Complete heart block in a patient of atrial fibrillation. Atrial fibrillation. No, fibrillation does not convert to flutter. Okay, so atrial fibrillation is going on and patient is taking digoxin, but it will result in toxicity. So if toxicity occurs, it will result in complete heart block. So now once the complete heart block occurs, what will happen? If it becomes complete heart block, that means atrial depolarization is not reaching the ventricle. So that means ventricle QRS, which was irregular in atrial fibrillation. Why? Because atrial depolarization was reaching the ventricle, that was resulting in irregular. Now it is not reaching the ventricle. So now ventricle escape rhythm will start the way we did in complete heart block. So escape rhythm will start, and this escape rhythm in ventricle, what would it be? It would be regular and slow. Regular and slow. It will be regular and slow. So to revise, your atrial fibrillation pulse or ventricle complexes are irregular normally, but when the patient is taking digoxin, resulting in digoxin toxicity that causes complete heart block, this will result in escape rhythm formation, and which will result in pulse becoming regular and slow. So from irregular pulse it becomes regular. Okay. So that means any patient of AFib on digoxin with regular pulse, it means it is what? Digoxin toxicity. This was the MCQ they had asked. Okay. In addition to this, same, what will happen in case of flutter patient? If he develops digoxin toxicity, what will happen? So in digoxin toxicity in a flutter patient, see in this case, now it will not be complete heart block that will develop. It will result in variable block. Variable block means, what do you mean by variable block? Initially I told you it is 2:1 or 3:1, whatever. It is constant in a particular patient. Okay, but now because of the variable block, what will happen now? Now it will happen is that, let's again draw the flutter ECG. These are the P waves. Now in this individual, what will happen? Because of the variable block, sometimes it will conduct 2:1, sometimes it will conduct 3:1, sometimes it will conduct 4:1, sometimes 1:1. So now what is happening? Because of the variable block, QRS is becoming what? Irregular. Okay, so irregular. Okay. So simple thing to remember, even if you don't understand all this, just remember is that in atrial fibrillation, digoxin toxicity results in irregular to regular pulse, whereas in flutter, it results in regular to irregular pulse, opposite effect. Okay. Because mechanism is different, it results in complete heart block in digoxin in atrial fibrillation, and it causes variable block in atrial flutter. Okay. So let's move on further. This thing is clear. So flutter is nothing much, but it becomes from 2:1 fixed block, it will become a variable block. So sometimes it will conduct 2:1, sometimes 3:1, sometimes 4:1. Okay. So a pulse will become irregular. Okay. Let's move on to the management of atrial fibrillation. Management of atrial fibrillation. See, whenever we talk about atrial fibrillation, you have basically patient comes to you with 3 symptoms. Okay. So number 1 is your palpitation symptom. Patient will have sudden onset palpitation, and that is what you have to take care of. How will you take care of palpitation? By controlling which rate? Ventricular rate. So by which drugs? Which drugs are to be given? So which drugs are to be given? A, B, C, D. Okay. So A, B, C, D are the drugs for palpitation. Next complication of atrial fibrillation. See what happens in case of atrial fibrillation. Your atria is depolarizing at a rate of 400-500 times per minute. So if it is depolarizing at 400-500 times, that means one wave of depolarization goes and other comes. So time is so less for each wave of depolarization that it does not depolarize the entire atrium. So one wave goes, other comes, other comes, other comes. So many waves comes in 1 minute. So it results in that the net effect is atria does not contract at all. So atria is not contracting. So if your atria is not contracting in atrial fibrillation, your blood stasis occurs. So if your blood stasis occurs, one of the virtuous triad. What is virtuous triad? Virtuous triad is your stasis, endothelial dysfunction, and hypercoagulability. So out of these 3 things, one stasis occurs in your case of atrial fibrillation, and you will have a clot formation. So clot formation you have to prevent, because once it is formed and results in stroke, there is no management. Yes, so you have to prevent the stroke, prevent stroke. So how do you prevent stroke? By giving anticoagulation therapy. Okay, so anticoagulation therapy is very, very important pharmacological part, anticoagulation therapy. So for anticoagulation therapy, we divide patients of atrial fibrillation into 2 groups. One is the valvular heart patients and non-valvular heart patients. So what are these valvular heart patients? That are more common we see in case of India, that is rheumatic heart disease. So young patient with rheumatic heart disease coming with atrial fibrillation. Okay, and non-valvular patients are who? These are generally old individuals, old age, then diabetic individual, all the risk factors of atherosclerosis, hypertension, diabetes, LV dysfunction, coronary artery disease, CAD. So all these are the risk factors for non-valvular heart disease, non-valvular AF. Okay, so you have valvular and non-valvular patients. So in case of valvular heart disease, to whom you will give anticoagulation therapy? All patients of valvular heart disease, you will give all patients anticoagulation therapy if they have atrial fibrillation. So atrial fibrillation with valvular heart disease, all patients need anticoagulation therapy. Okay. So what is the anticoagulation of choice? Warfarin is the drug of choice in case of valvular patients. And for warfarin, see, this is an age-old drug. So some of the drawbacks of warfarin you should know. Warfarin, it has high interaction with drugs interaction. it has food interaction. INR is to be monitored. You cannot just start the warfarin at a fixed dose for all individuals. There is no fixed dose. You have to titrate according to the INR. So what is INR? International normalized ratio. So don't go into detail. INR. Okay. So just remember INR is to be monitored, and you have to maintain INR between 2 to 3. Okay. So that is the management to prevent stroke in a patient of valvular heart disease with AF. Okay. Next patient, non-valvular heart disease with atrial fibrillation. How to manage the anticoagulation therapy? Let's see. So in a non-valvular patient, okay, anticoagulation. Not all individuals you have to start the anticoagulation therapy. There is a scoring on which basis you have to start. This we call as CHAD S2 VASC score. This is the complete score. Okay, write down the score. I'll tell you the full form. What is the full form? C stands for CHF, H stands for hypertension, A stands for age, more than 74 years. Okay, D stands for diabetes, basically all the risk factors for atrial fibrillation. S stands for previous stroke. V stands for vascular disease. What do you mean by vascular disease? Any atherosclerotic vascular disease. Atherosclerotic vascular disease. Like you have CAD, you have renal artery disease, you can have peripheral artery disease. Okay, so all these are vascular diseases. A stands for again age. A stands for age. What is age? Age, this time age is 65 to 74 years. Previously it was more than 74. This time it is 65 to 74. And SC is nothing but sex category. That is, which sex category? Females. Okay. So you have the entire full form of this thing. So we give one score wherever there is not written 2, we give one score to each factor, and we give 2 score to the points where it is written 2. So stroke has 2 points, age more than 74 has 2 points, whereas rest of the age, if it is 65 to 74, you will have 0.1 only. Okay, so on this basis we calculate the score in an individual. So that means if a patient of diabetic comes to you, age 80-year-old, so what is the score? Score becomes 2 for age more than 74, 1 for diabetic, and if she is a female, then 1 more point you add, so total becomes 4 points. Okay, like this you have to calculate the total point for an individual. So this is what is CHAD S2 VASC score. So on this basis we will decide whether we have to give anticoagulation therapy or not to give. So how do you decide? If CHAD score is 0, then no anticoagulation therapy. If CHAD score is 1, you can give either antiplatelet or anticoagulation. And if your score is greater than equal to 2, then Anticoagulation therapy only. Anticoagulation. Okay. Now comes which anticoagulation. Which anticoagulation you will prefer? Not warfarin. Warfarin is a old drug nowadays. Warfarin is not recommended. It's not preferred. Not recommended is a wrong term, but not preferred. There are better drugs available. Okay, so this was the MCQ asked in 2011 AIMS. See, what is the, there are so many answers you people are giving me, enoxaparin, LMWH. See, always remember these individuals of atrial fibrillation, you cannot keep them admitted in the hospital. Yes or no? You have to give a chronic therapy for anticoagulation. Chronic therapy can never be injection. It can never be any injection. It has to be what? It has to be a tablet. Okay. So this is very, very important point. It has to be a tablet. So now, which tablet you will give? Warfarin is the old oral anticoagulant that was available. But nowadays, newer anticoagulation therapy is available. So that means, what are the newer anticoagulants that are available? Yes, any of the newer anticoagulant that you are aware of? Dabigatran, very good. Dabigatran is one newer anticoagulant that is available. It's not LMWH. LMWH is an old, but it is dabigatran. This was the MCQ asked in 2011, the year when dabigatran was approved by FDA. FDA is the Federal Drug Authority, that is of US. Okay, so whenever US approves any drug, that we are very smart people. Okay, we don't have our own authorities to pass the drug. So what we do is, whatever drug they pass, we also pass. So what is the drug? Dabigatran they approved in 2011, and that came as an MCQ. So what was the MCQ? Newer oral direct thrombin inhibitor. So that means they asked, what is dabigatran? Dabigatran is nothing but direct thrombin inhibitor. So it's, nowadays there are so many other drugs that have come. So it all becomes very confusing. What is the anticoagulation? What is the property? Which is a direct? Which is indirect? Okay. I generally tell my students this classification. So I tell you also because it becomes very easy after this classification to remember the properties of these anticoagulation therapies. Okay. Let me tell you how you classify. See, sometimes it's easy to remember things if you remember their evolution. See, what happened was, initially the first molecule that came into being, it was a unfractionated heparin. Unfractionated heparin. Okay, so what was the molecule? It had a long tail and a pentasaccharide base. Okay, this was an indirect acting. What do you mean by indirect acting? Indirect acting. Indirect acting means it required which molecule to act? Antithrombin 3, AT3 to act. Okay, and now they bound to two factors, factor 2 and factor 10. This was your indirect inhibitor, that is unfractionated heparin, that came first. Okay, but there were so many drawbacks of unfractionated heparin. You had to give it as a continuous infusion. Continuous infusion. Second, you have to monitor its therapy. How do you monitor heparin therapy? Unfractionated heparin therapy. Which test? Yes, anybody? Which test? Not PT. Don't write PT. APTT. APTT is used for monitoring the heparin therapy. Every 6 hourly you have to do it, and it's a costly test. Okay, so that means then absorption was not predictable, not predictable absorption. So there were so many drawbacks of unfractionated heparin. So what happened was, scientists discovered that if you cut down the tail, decrease the tail, what will happen? If you reduce the tail, this molecule becomes low molecular weight heparin. That means weight will reduce by reducing the tail. So now the properties will improve. There will be improvement in the properties of this molecule because now it becomes low molecular weight heparin. So low molecular weight heparin was nothing but a modification of unfractionated heparin. Okay, so what has happened is tail is gone, small, tail has become small. So now low molecular weight heparin, it will bind to factor 10 more powerfully than factor 2. Why? Because factor 2 requires tail, whereas tail has become small now. So low molecular weight affinity for factor 10 is more than affinity to factor 2, and low molecular weight is an indirect inhibitor because it is evolved from unfractionated heparin. Okay, now further scientists discovered that if you cut down the tail altogether, you remove the tail altogether, what will happen? You only have a pentasaccharide molecule, no tail. Now again, it will again bind to antithrombin 3, but only factor it will bound to is factor 10. No factor 2 would be there. And this molecule is, what is this molecule? Yes, anybody? What is this molecule? Fondaparinux. Fondaparinux. Absolutely right. Fondaparinux. Okay. So you can see how the things have evolved from unfractionated heparin to low molecular weight heparin with more affinity to factor 10. Why? Because tail got small. And now with absence of the tail, you have fondaparinux which binds only to factor 10. So all these three are indirect inhibitors, and all these three are to be given parenterally. That is IV, subcutaneously, whatever. Not orally. Okay. So now scientists, they wanted some oral drugs to be given for individuals like atrial fibrillation, for individuals like pulmonary embolism. You have to continue therapy for 6 months. For DVT, you have to continue therapy for 6 months. So you cannot continue these injections. So you have to have an oral therapy. So only oral therapy initially was available was warfarin. But warfarin had so many side effects, I told you. So let's talk about the new oral anticoagulants. New anticoagulants. These are direct inhibitors. They all are direct inhibitors. They do not require which molecule? They do not require antithrombin 3 molecule. They do not require AT3. Okay. So now either they can block factor 2 or they can directly inhibit factor 10. Okay. So let's talk about factor 10 first. Why? Because these drugs, they have recently came in India. They have been launched just 1 month back, and whereas in USA they came 1 year back. So these are the latest anticoagulants that are available, and for you we are only concerned with the MCQ. So if any drug that has in the end hexaban, that is your 10A direct inhibitor. Okay, so it will be apixaban is the new molecule. Write down the way I have written, or it can be endoxaban. Okay, it can be rivaroxaban. So for you it's easy. If you have hexaban in the end, whenever you have hexaban in the end, that means it is a 10A direct inhibitor. Okay. Now factor 2 inhibitors. Factor 2 inhibitor, these are of two types. Either you can have oral inhibitor, you have IV also available in this. Whereas 10 were all oral inhibitors. They were all oral inhibitors. Factor 10 inhibitors. Rivaroxaban. Hexaban is in the end. common to all. Okay, so oral and IV. Now oral is the drug that you already know, that came as an MCQ, that was a dabigatran. This is the oral direct factor 2 inhibitor. And IV are all drugs derived from hirudin. What do you mean by hirudin? Hirudin is a chemical that you see in the saliva of leech. Yes, so you have a saliva of leech where you see this hirudin. So any molecule derived from hirudin is IV factor 2 inhibitor. So in the end, I'll write over here, in the end you will have hirudin in the end of the name. So in the beginning, let me write bivalirudin, BIVAL plus hirudin, or you can have lep plus hirudin. So this is the total molecule, lepirudin, bivalirudin. Yes, so lepirudin, bivalirudin, but in the end you will have hirudin. So just to remember, so that in the MCQ when you are answering, you can easily remember it. Hirudin means IV2 inhibitor. IV2 inhibitor. Okay. So this is hirudin means IV2 inhibitor. So this year, those who are regular batch, who are going to appear for the entrance exam, so just remember apixaban, endoxaban, rivaroxaban, these are the new anticoagulants, oral anticoagulants that can come as an MCQ. Okay, dabigatran has already come. Now the only thing that can come is the properties of dabigatran. Okay, so that you have to do from your pharmacology. I won't go into details, and that finishes your anticoagulation. And this way I think you can remember your anticoagulants very well. Okay, so we have done the anticoagulation therapy in case of atrial fibrillation. So now some of them are asking me what is adenosine. A stands for adenosine or amiodarone. See, AV nodal blocking drug, adenosine we are talking about. Okay, obviously you will not give adenosine chronically to an atrial fibrillation patient. Adenosine is a short acting drug. You have to, acetylene is nothing but it is a kind of warfarin. It is a kind of a warfarin. Okay, let's move on next. The third part that we have to manage in atrial fibrillation, see, you have to understand it. See, what happens is, most of the times the patient comes with arrhythmia, they are symptomatic because of the palpitation. Okay, now when we talk about palpitation, we have already discussed how to manage the palpitation. But even when you control the ventricular rate, after that also some patient remains symptomatic. So why they are symptomatic in atrial fibrillation? So what happens is, see, if you remember your physiology class and your cardiac cycle, I'll just briefly tell you, in the cardiac cycle there are two parts of filling. One is your passive filling, the other is your active filling. Right? So when you talk about passive filling or active filling, when I say active filling, see, in active filling what happens is, atria contracts and pushes the blood into the ventricle, that is your active filling. Yes or no? So now, in case of atrial fibrillation, what will happen? Your atria is not contracting. So what type of filling will be gone in these patients? In these patients, you will not have active filling there. Yes. So normally, so what will happen? Your cardiac output will decrease in case of atrial fibrillation because your active filling is gone. Right? So these individuals will be symptomatic. Why? Because their cardiac output is less. So when they run, they need more cardiac output, but their cardiac output is less. So they will have syncope. They will have breathlessness. Right? So these are the symptoms that they will still have despite controlling the ventricular rate. So how will you manage syncope, breathlessness? How will you manage? That means you have to bring back what? Atrial contraction. So that means you have to bring back your atrial contraction. Okay. So the point is, how do you bring back your atrial contraction? Atrial contraction can be brought back by converting atrial fibrillation to sinus rhythm. Okay, so we are just talking about the management, third part of the management in atrial fibrillation, that is syncope and breathlessness management. Why? Because of their reduced cardiac output. So atrial fibrillation has to be converted to sinus rhythm. We call it as cardioversion. So how do you do cardioversion? There are two ways of doing cardioversion. Number one, it is the DC cardioversion that you do, and another is your pharmacological cardioversion. Pharmacological cardioversion. Okay. Now when do we do DC cardioversion? See, DC cardioversion whenever patient is unstable, hemodynamically unstable in any arrhythmia, you have to give DC cardioversion. But if patient is stable, then you can give pharmacological cardioversion. Okay, now let's talk about more details about cardioversion. Number one, when do you do the cardioversion? See, the patient of atrial fibrillation comes to you, and now you are planning, okay, patient symptoms you have to are of syncope, breathlessness. Now you have to do the cardioversion. You have decided to do the cardioversion. When do you do the cardioversion? What will happen? See, if the patient already has a clot in atria, so what will happen? Initially your atria is not contracting, it is just depolarizing at a rate of 400 beats per minute. That is, atrial fibrillation is going on. So blood is in stasis, so there is a clot formation. So if this clot is there and now you do the cardioversion, what will happen? Suddenly atria will start to contract. This atria which was not contracting suddenly starts contracting. What will happen to the clot present in the atria? It will embolize. And the moment clot embolizes, the patient will develop stroke. So the first thing before you do cardioversion, you have to rule out what? LA clot. So how do you rule out LA clot? So LA clot you have to rule out is by doing some investigation to rule out the clot. So if there is a LA clot present, you have to rule it out, and then what is the investigation? In cardiology, for all investigation it is always echocardiography. If you have to see any structure, it is always echocardiography. But there are two types of echocardiography. What are the two types of echocardiography? One is transthoracic. See, this you have to understand, transthoracic, and the other is transesophageal echocardiography. Okay, so if I try to explain you, see, this is, I again draw, if this is your heart in the thorax, within the thoracic cavity. Okay, now transthoracic, if you can see me, you do the echo from the outside the chest wall. So if you put a probe over here, if I try to see the heart, I have put a probe at the apex, let's suppose, fifth intercostal space, mid clavicular line, I have put a probe, echo probe. Okay, and I am seeing the heart. So what do you think? Which chamber would be better visualized? Ventricle or the atria? Ventricles would be better visualized rather than the atria. Yes or no? Okay. So if any clot is there in the ventricle, you can see very clearly. But over here, which clot you want to rule out? It is the LA clot, not the ventricle clot. So now let's suppose if I put a esophageal probe. What is esophageal probe? Esophageal probe is nothing just like an endoscopy. You put it in the esophagus, and from the esophagus lies posterior of the heart. It lies posterior to the heart. Okay, if I put a esophageal probe over here, this is my esophageal probe. Now this is visualizing the heart from behind. So from behind, which chamber is best visualized? The best visualized would be your atria, right? So if your best is visualized atria, so that means LA clot is there, so that you can always diagnose with transesophageal echocardiography. Okay, you will never do transthoracic echocardiography. Why? Because see, these things are very, very important practically. If you have a patient of atrial fibrillation, let's suppose I do the cardioversion, and the moment I do cardioversion and he develops the stroke. So this is a medico-legal issue. He will sue me. And I cannot say, oh, I did the transthoracic echo and sorry, I am very sorry, I just missed the LA clot. So you have to be very damn sure that there is no LA clot before going ahead with cardioversion. Okay, so now T is the investigation of choice in the situation where you have to rule out LA clot. So similar situation I'll just cover it here only because there was an MCQ on transesophageal echocardiography. See, whenever you have to rule out any LA disease, you will do transesophageal echocardiography. So in this case we have done that LA clot to rule out LA clot, but in other diseases like infective endocarditis, write down the other uses of transesophageal echocardiography. In a box, write down other uses of transesophageal echocardiography to rule out infective endocarditis. Again, vegetation can be on the atrial side, it can be on the ventricle side. So if you have to be sure that there is no vegetation, you have to do transesophageal echocardiography. Okay, third is aortic dissection. Aortic dissection is not clear in case of transthoracic when you do, whereas see in the same diagram I try to explain you where is your aorta. Aorta goes like this. Okay, so you have a probe over here. It can also visualize the aorta. So you can see aortic dissection. We'll cover aortic dissection in the next topic, management of acute chest pain. I'll come to that. So aortic dissection is the first, is also the investigation of choice is transesophageal echocardiography. Am I clear? So is that clear to all? Okay. So next, if the patient has LA clot, then what? If the patient has a LA clot positive, then you will give anticoagulation therapy and later on call the patient again for transesophageal echocardiography and again see whether clot is there or not. And if the patient has no clot, go for cardioversion. No clot, go for cardioversion. Okay. So now this is all about whether to do cardioversion or not. Once you have decided and you have ruled out the LA clot, now what type of cardioversion? Which drug will you use in pharmacological cardioversion? Let's talk about pharmacological cardioversion first, and then I'll talk about DC cardioversion. Okay, pharmacological cardioversion, what are the drugs that we use for pharmacological cardioversion? Already many people have typed many drugs they are typing. See, just pharmacological cardioversion, you have to divide the patient into two types of condition. One is the patient has structural heart disease. Structural heart disease means like the patient has LV dysfunction, patient has LV hypertrophy. So some kind of structural heart disease is there, whereas another patient there is no structural heart disease. Let's suppose only patient is age more than 75 individual, only risk factor is the age, and he comes with atrial fibrillation, no structural heart disease. Okay, so what are the drugs that you can use in the two conditions? In structural heart disease, the drug that is used is your, which one? Amiodarone. Amiodarone is the drug that you use as a drug of choice for structural heart disease. And in those patients who have no structural heart disease, you use 1C class of drugs. 1C class of drugs. What are these 1C class of drugs? Yes, what is the 1C drugs? You have been asking me 1C, 1C. 1C is, what is the mnemonic? Provides more flexibility to the management. Provides more flexibility. So what are the drugs? Propafenone, morphine, flecainide. So these, ticainide is another one that has come nowadays. So in the end, if you have inide, that all are class 1C drugs. So now these are propafenone, morphine and flecainide. So these are the three drugs that are used in case of no structural heart disease individual. Okay. Another drug that many people are writing, that is ebutilide. This is not available in India, but it can be used for cardioversion. Generally, it is used along with DC cardioversion. Okay, so ebutilide you also write, and this is which class of drug? Which class? Ebutilide. Yes, those who have written, Mysore has written ebutilide. Which class of drug? Class 3. The other people are saying Mysore has cheated now, huh? So class 3 drug. Ebutilide is a class 3 drug along with amiodarone. So over here, see, the question can come as a class of drug, one thing that can anytime come. The another thing is, important point is, along with amiodarone, you should know what is dronedarone. What is dronedarone? Yes, if in one line, if you can tell me what is dronedarone? See, dronedarone is nothing but amiodarone without iodine. That is, dronedarone is a new molecule. Yes, very good. It is a dronedarone is amiodarone without, it is without iodine. So all side effects because of iodine do not occur with dronedarone. Okay, so what are the side effects of iodine? Yes, you have done your physiology class. If I give iodine to an individual, what are the side effects that he can develop? Hypothyroidism. Why? What is the phenomena? What is that effect? No. Jod-Basedow effect, Wolff-Chekhov effect. Very good. So Agartala gives the answer. Wolff-Chekhov effect is the cause of hypothyroidism. Wolff-Chekhov effect. Mysore is also right. Wolff Chekhov effect. Iodine can also cause hyperthyroidism. Now what is the mechanism? Yes, somebody told me, Bilaspur told me. Jod-Basedow effect, right. So this you must have done in your physiology or in endocrine. I need not tell you what exactly they are. So these all side effects will not be there with dronedarone. Okay. But recently there was a trial that showed that dronedarone causes increased mortality. So it has been withdrawn from the market. Nowadays nobody uses dronedarone. Okay. So that you should remember that it causes increased mortality. So it has not been, nowadays it is no longer used. Okay. Now let's move on further. So that was all about the pharmacological cardioversion that we had to discuss. Next is your DC cardioversion. I'll just tell you briefly about DC cardioversion, because see, many a times we go for MCQ paper and we realize that whatever things we have done, they have not asked. The paper was so general. Yes or no? Many times this happen. And this I generally call this as a common sense about medicine. And this common sense, how do we acquire this common sense is, generally examiner expect that you attend your internship posting very sincerely, you go for your postings, you see the cases there, you see the management there. So that is how you should acquire your common sense. So he will time and again ask you questions which are more of practical orientation rather than theoretical orientation. Like, just for example, we discuss about anticoagulants. So for anticoagulants, if we discuss, your IV anticoagulation you will not give for chronic therapy, any chronic therapy. So any choice of IV anticoagulation, that will be out. You know all the drugs, you know IV and oral, but you don't know, oh, this is a chronic condition, we need not give IV. So that will be the basic difference between a person who has the common sense, who doesn't has the common sense. That does not mean you are not intelligent if you don't have the common sense. Okay, this is not that type of common sense. This is what is that your practical exposure is there or not. Okay, but see, practical exposure I cannot give you. So I can only give you is the practical knowledge about the things. That is why I keep telling you about the pacemaker. I keep telling you about the how we give the drugs, what is the management. That is why I keep telling you all this. Okay, so practical aspect regarding DC cardioversion. Let me tell you about DC cardioversion. You must have seen DC cardioversion in your wards. Yes or no? Have you ever seen? Bilaspur says yes. Mysore says yes. Okay. I cannot directly ask you questions, so you can say yes. Okay. So if you have not, if you have not given or seen DC cardioversion in the ward, you must have seen on the movies. Yes. So it's more or less the same, but end result may be different. What is there in the movies, all patients survive. Whereas in the real life, many few survive. Yes or no? Those who have seen it, most of the time it is just a futile exercise. We are just jumping on the chest without knowing what is going on. So in-house MD you have seen. Okay. So that is a very dramatical presentation. Okay. Okay. We'll go ahead. What is DC cardioversion? See, in DC cardioversion, when we give DC shock, how do we give DC shock is important. This comes as an MCQ also. You should know there are two types of DC shocks that we can give. One is monophasic and the other is biphasic. So monophasic, it used to be earlier given. It was an old technology. So we needed higher energy, that is 360 joules we need to give for cardioversion. That means higher energy. So that means monophasic is what? Less effective. Biphasic on the other hand is a new technology. It is more effective. So that means more effective means you have to give less energy. So these biphasic machines, they have upper limit generally of 200 joules. Some may have 250, but that is maximum. 2 under 250, that is the maximum. Okay, so one difference is this. Second difference is, how do you give the shock? We call it as synchronous shock or non-synchronous. See, these are general topic, nobody will tell you. So I am just telling you, synchronous or non-synchronous. So synchronous means, when you switch on the synchronous in the machine, that means machine synchronizes the time of delivery of the shock with a particular wave in the ECG. So which wave is most prominent in the ECG? R wave. So that means it will synchronize with R wave. So whenever you press synchronize button, it will synchronize with R wave. So whenever there is a peak of R wave, it will give the shock. So it will be most effective. Synchronous shock would be most effective shock. So you require less energy when you are giving synchronous shock. Okay, but what are the conditions where you don't have R wave, where you cannot give synchronous shock? Any condition where you don't have R wave. Just like atrial fibrillation, you do not have a P wave. In case of ventricular fibrillations, good, you do not have R wave, no R wave. This would be like this. QRS would be like this in ventricular fibrillation. No, in CHB you are wrong. CHB you will have R wave, but this R wave would be coming from where? It would be escape rhythm R wave. Okay, you will have an R wave, and anyhow you will not give shock in case of CHB. CHB does not require shock. It is not an arrhythmia. It is a bradyarrhythmia. It is not a tachyarrhythmia. So for bradyarrhythmia you will not give DC shock. You will give pacemaker. You have to increase the heart rate. Whereas for tachyarrhythmias, CHB means complete heart block, right? So for tachyarrhythmias you will give the shock, not for bradyarrhythmias. And for tachyarrhythmia, ventricular fibrillation, where there is no R wave, you will give non-synchronous shock. Okay, so let's move on further. So this is how you can classify your DC shock into various aspects. This can come just as a general MCQ. And next point is, okay, I'll stop here for DC shock. We'll discuss about these things later on. Okay, further few points we have to discuss, we'll discuss later. Okay, that finishes the management of atrial fibrillation. Any doubt about atrial fibrillation? Now comes the management of, see, cardioversion and defibrillation, it is one and the cardioversion means converting atrial fibrillation to sinus rhythm. So that can be done by two ways. One is the DC shock, that is direct current that you can give, and you call it as defibrillation. Okay, whereas pharmacological cardioversion will not be called as defibrillation. Okay, so now you yourself tell me which is better, monophasic or biphasic. Which will you prefer? Which is more effective? Biphasic is more effective, so obviously you will prefer biphasic. So there is no doubt about it. Okay, so another important point, now this atrial fibrillation management is gone. Now let's talk about atrial flutter management. Atrial flutter management is the same as atrial fibrillation management. You have to manage all the three things. One is palpitation by blocking the AV node. Number two, you have to prevent clot formation. Number three, you have to convert it into sinus rhythm. Okay, but what is the difference? Difference is, number one difference is that rate control, that we call it as ventricular rate control, is difficult in atrial flutter as compared to atrial fibrillation. This you should understand. Okay, just write down this line. What are the differences between fibrillation and flutter management? Flutter rate control is difficult. Number two, for cardioversion in flutter, DC shock is preferred over pharmacological cardioversion. DC shock is preferred over pharmacological cardioversion. Rest everything is same, anticoagulation therapy is the same. Okay, so this is 1C drug that we discuss. I told you 1A and 1C in WPW, not 1B. Okay, let's move on to another arrhythmia. What is that arrhythmia that is left is ventricular tachycardia. We'll just rapidly finish it off. Ventricular tachycardia, when I say ventricular tachycardia, basically that means ventricular rates are very, very fast. What are the ventricular rates? More than 200 are the ventricular rates. Just at your level, remember this thing. Okay. So, just for Jammu, I'll just let you know because on that topic only you have asked me. Monophasic and synchronicity, these are two different aspects of the shock. They are not the same thing that you say monophasic or synchronous. No, they are two different things. Monophasic shock can be synchronous or dissynchronous. Biphasic shock can also be synchronous or dissynchronous. Okay, so these are two different properties you can program anyways. Okay, okay. Let's talk about ventricular tachycardia. Ventricular tachycardia rates are more than 200 ventricular rates. Now we divide it into two. One is monophasic and another, monomorphic and polymorphic. So what is monomorphic? What is polymorphic? Monomorphic is nothing but when ventricular tachycardia rates morphology is same. See, this is the ventricular tachycardia. What is this? All QRS are of same morphology. So this we call it as monomorphic. Polymorphic. What do you mean by polymorphic? One QRS is like this, second is like this, third is like this, fourth would be somewhere like this. So you have a different morphologies of ventricular complexes. So that becomes polymorphic ventricular tachycardia. Okay, now let's talk about the management. We'll discuss about polymorphic, which comes as an MCQ. Polymorphic we divide into further two, whether you have a normal QT interval or increased QT interval. So increased QT interval with polymorphic VT, what is that VT known as? Specific term. Torsades de Pointes. Okay. So TDP, Torsades de Pointes. What is the management of TDP? Increased QT, I have already told you the factors that can cause increased QT. So what is the management? First management is IV magnesium. Second management is IV magnesium is the first management. If still it continues, you have to give drug that does not prolong QT. Any antiarrhythmic drug that does not prolong QT, we have already discussed. Yes, what are these drugs which does not prolong QT? Antiarrhythmic does not prolong QT. Anybody? I have already told you. Not. Oh yeah, class 1B drug. You are right. Not class 3, class 1B. And digoxin, you will not call it as anti-arrhythmic drug. Okay, you are giving for controlling the rate only, ventricular rate. You are not cardioverting it. Okay, so digoxin is not a anti-arrhythmic drug in that sense. So class 1B drug. So another next drug would be class 1B drug that you will give. Good. Okay, so that is all about the management of polymorphic VT. And if I tell you the management of monomorphic VT or normal QT VT, what are the management of these? Amiodarone is the management. Amiodarone or DC shock. depending on patient is hemodynamically stable or hemodynamically unstable. Okay, so that finishes our arrhythmia chapter. Let's you want to do some of the MCQs. Let's see what type of MCQs generally comes. And PSVT I've already discussed in WPW, so we'll discuss further during your MCQs. I don't think we can show these MCQs because they already have the answers with them. Generally we highlight them in the class. Okay, anyhow we can discuss them without just talking about their. Okay, we'll do this MCQs and then we'll see. Drug of choice for PSVT in a patient of COPD on oral darifilin. See, I already told you if a patient is of COPD, that means that adenosine is contraindicated. Why? Because it causes bronchoconstriction. Okay, and verapamil is the drug of choice. See, what happens is darifilin is a contraindicated. No, beta blocker. Can you give beta blocker in a patient of COPD? You yourself decide. And another thing is verapamil is the drug of choice, and adenosine will whenever you have any side effect of adenosine, the drug of choice is your darifilin. So darifilin is basically nothing but it is a antidote for adenosine. So whenever you have a darifilin patient taking darifilin, adenosine will not have any effect. Okay. A patient develops sudden palpitation with heart rate of 150 per minute regular. What could be the cause? What could be the cause? See, in such a question, I told you how to differentiate between the different type of palpitations on the basis of your history. So this patient has a sudden palpitation. So sudden palpitation means it rules out sinus tachycardia. So that means there is no sinus tachycardia. First of all, this is arrhythmia. Second is it is a regular tachycardia. So atrial flutter with block. See, whenever they mention only atrial flutter, that is understood that atrial flutter with fixed block, that is 2:1 or 3:1, that means atrial flutter would be a regular flutter. Ventricular rate would be regular. But when they say atrial flutter with block, that means what? Atrial flutter with block means it is a variable block. Variable block because of digoxin toxicity. So what would be the heart rate? Heart rate would be irregular or regular? It would be irregular. So whenever they mention atrial flutter alone, it is a regular heart rate. Whenever they mention atrial flutter with block means specifically they are mentioning block. That means they mean variable block. Okay, so at that time atrial flutter rate would be irregular. Okay, so your question rules out this thing also. So last two choices that remains PSVT and ventricular tachycardia. PSVT I did not tell you, the common rates in PSVT are 150 to 250. Generally heart rate is 150 to 250. Whereas ventricular tachycardia I told you the rates are more than 200. So in this individual heart rate of 150, it is most likely to be PSVT. Another important MCQ that comes on question like this is that with normal LV function, they will write a patient develops sudden palpitation with heart rate of 150 per minute. On echo, heart is normal. Normal heart on echo. That again means, what is the diagnosis? Sinus tachycardia, because it is sudden onset. Sudden onset does not mean, sudden onset can never be sinus tachycardia. See, whenever you run, I told you, whenever you run, it is a gradually that your heart rate increases. But in arrhythmia, what happens? Patient is sitting or sleeping, suddenly his heart rate increases. So that is why you differentiate. Sudden palpitation means it cannot be sinus tachycardia. Okay. So another important point is, if your LV function is normal and patient has tachycardia, so that again points towards diagnosis of PSVT or sinus tachycardia, one of these. If it is sudden onset, then it will be PSVT. If it is a gradual onset, then it will be sinus tachycardia. Okay, so that again another MCQ that comes. Okay, a person with MR and AF presents with syncope. On examination, the person has a heart rate of 50 beats per minute regular. I'll speak it out. What is the most probable cause? See, what is this patient having? MR with AF. That means valvular patient with atrial fibrillation coming with syncope. Okay. Now his heart rate is 50 regular. That means slow heart rate and regular. So what do you think is happened? The complication that has happened because of digitalis toxicity. What is the complication that has happened? This patient has developed what? No, it is digitalis toxicity. It's already written. It's visible. But CHB, yeah, that is the right answer, Vishakhapatnam. It is a complete heart block that has occurred and escape rhythm is occurring. Okay, so that is why you have a regular heart rate which is slow. Okay, see this 2011 AIMS November question, dabigatran they asked. So this time when they ask you, this will be more of what? Apixaban, rivaroxaban, those are 10A inhibitors. Okay, so transesophageal echocardiogram is superior to transthoracic echocardiogram because of, this was the MCQ that they asked. Now you can easily answer it. Transesophageal, what do you think? Transesophageal is superior to transthoracic. Why? Is transesophageal convenient? Do you think it is convenient for the patient to take transesophageal probe? It's so inconvenient. That is why we don't do it routinely. Is more sensitive in picking up ventricular thrombus. Is it so? Transesophageal? No. What about okay, this I'll pull it up. Third choice is more sensitive in picking up atheromatous plaques in ascending thoracic aorta. This choice can be or cannot be, because I told you aortic dissection, if you apply that concept, it can be. Okay, just remember, you just keep it in a reserve. Let's come to the fourth choice. Transthoracic is more sensitive in picking up atrial appendage thrombus. Which is more sensitive, transthoracic or transesophageal? Transesophageal is more sensitive. So again, this choice is wrong. So you have three choices wrong. Even if you did not know the third answer, by knowing your existing knowledge, you can answer that third is the answer. Yes or no? So in the exam, always remember this. I keep telling you, keep telling my students that don't think that you will know each and every subject, a complete subject. You are not here to do master in all 19 subjects. You should know whatever is important, build up your concept so that on the basis of your concept only you can answer the MCQs. Okay, so you have to be jack of all trades, not master of all. If you try to be master of all, you will never become a master of even one subject. That means you will never clear your PG entrance. Yes or no? Okay. Fourth, you yourself read it again. Which is more sensitive? Transthoracic or transesophageal? So, this is true or false? Okay, let's move on further. Okay, that is all about the MCQs in case of your tachyarrhythmias. Let's me discuss some of the bradyarrhythmias MCQs, how they come. Constant PR interval is seen in first degree heart block. You all know it is constant. Second degree Mobitz type 1, second degree Mobitz type 2, complete heart block. If it is only one answer, then better answer would be first degree heart block, because it is always constant, there is no drop in P wave. Whereas in case of second degree heart block, Mobitz type 1, you gradually PR prolong, and then suddenly 1P does not conduct. Whereas second degree Mobitz type 2, what happens? PR is fixed, but suddenly 1P will not conduct. So that P which does not conduct, you may call it to be PR prolonged, but actually it is not there. So if it is a multiple choice answer, you can say it to be first and third answer to be correct. Whereas if it is single answer, you can say first degree is better answer. Complete heart block, whenever it is a complete heart block, we do not talk about PR interval. Why we do not talk about PR interval? We talk about PR interval only when the atrial depolarization goes to ventricle and results in ventricle depolarization. In case of complete heart block, it is not happening. In case of complete heart block, what is happening? Ventricle has a escape rhythm which is starting within the ventricle. So both are independent of each other, resulting in AV dissociation. Okay. So that is that will not be considered as an MCQ, not an answer. Okay. So that I end my MCQs over here, and we can start our next topic, that is ventricular. I'll start my next topic, that is acute chest pain. Acute chest pain. Okay, I'll take few questions. There are few questions that are coming up. Ventricular fibrillation. See, ventricular fibrillation is unstable rhythm. So what is the management? You yourself tell me. I told you all unstable arrhythmias, only one management. What is that management? DC cardioversion. So ventricular fibrillation, DC cardioversion. Again, mechanism of action of adenosine. You should not ask me, you should answer me. Pharmacology class is already over. Yes or no? Yes. So the management of answer is answer of mechanism of action of adenosine. See, adenosine, when I said deriphyllin is an antagonist of adenosine. So that means what? Deriphyllin, what is the mechanism of action of deriphyllin? Deriphyllin is a non-selective phosphodiesterase inhibitor. So that means it inhibits the phosphodiesterase activity. So phosphodiesterase activity it inhibits. So what will adenosine do? It will increase the phosphodiesterase activity. Okay. So that is the mechanism of action of adenosine. There are few things that how to differentiate PSVT or SVT versus VT. I did not discuss. I thought you people will not understand that topic. So if you want, I can discuss that topic, VT versus SVT. Okay, we'll do one thing. We'll continue with our class, and VT versus SVT you will discuss in the end. Okay, so that we'll talk about it, antiplatelets and all that. Don't ask me pharmacological subjects. Whatever is there, I'll teach you whatever comes in between. Okay, so drugs, whatever comes, I'll try to teach you. Okay, let's start with acute chest pain. Now, Okay, acute chest pain. Let me start. I'll just give you an introduction, and then if you want, we can take a break for 10 minutes, and then subsequently we can continue. Okay, I'll just introduce the topic and then we'll take a break. Acute chest pain. See, the most important cause for chest pain, not the most common. I'm not asking about most common, but the most important cause of acute chest pain. If any person has acute chest pain, obviously I'm talking about the left-sided chest pain. Right-sided chest pain, we are not concerned. Okay, so we will talk about acute chest pain, that is your left-sided chest pain. The most common, not the most common, but the most important cause is your MI. So if any question comes and they don't give you any clue about any diagnosis, and they ask you what is the first investigation that you have to do in a patient of left-sided chest pain, first investigation is what? ECG. Always remember this. You always carry with home with you whenever you practice also. Okay, because see, whatever theory we do today, it has a practical importance also. I know MCQs are important. This is important from MCQ point of view, also from your practical aspect also. If somebody says, sir, I have acute chest pain on phone, somebody calls you, first thing you should ask them is get an ECG done. This is simple tool, easy to do, and this can rule out a very serious complication, very serious etiology, that is MI. Okay, so first thing is ECG. Now let's talk about the history that will tell you whether this chest pain is ischemic in origin or is it non-ischemic. Ischemic means myocardial ischemia. Ischemia, see, one basic concept I would like to tell you is whenever patient complains of chest pain and he has decreased blood supply to the myocardium, so what is happening is ischemia is happening. So if there are two scenarios, one is that myocardium is alive but it is receiving less of blood. Myocardium is alive. Okay, then only it will cause chest pain. That is what is ischemic chest pain. If your myocardium is already dead, even if the blood supply is less to that area and myocardium is already dead, it will not cause pain. That you already know that, see, dead bodies, they cannot speak. Can they speak? So dead bodies cannot say that, oh, I have pain. So similarly, dead myocardium will not cause pain. Whereas it is the live myocardium which causes pain. And why it causes pain is so that the patient goes to the doctor and takes treatment. This is to drive the patient to take treatment that this pain occurs. Okay, so it is always the ischemia that is happening that results in pain, not the infarction. Infarction means dead tissue. So it is not infarction that causes pain, it is ischemia that causes pain. Okay, now let's talk about ischemia. What is the kind of chest pain that it happens? We'll discuss this thing and then we'll take a break. After that, we'll discuss the differential diagnosis. Okay, so what are the features of ischemic chest pain? Number one, obviously it is left-sided precordial chest pain, left-sided chest pain. There is something known as Levine sign. What is Levine sign? Levine sign. See, whenever patient of MI, not even MI, any angina comes to you, yeah, you have absolutely described it. Two words, fist and squeeze. That is the two things that explains the Levine sign. That means patient comes with a fist and saying that, oh, I have a squeezing chest pain, compressing chest pain. That means what? One thing is, fist says that it is diffuse in character. It's all over the precordium. It's not at a particular point. He is not pointing out. He is saying fist. Making a fist means it is diffuse chest pain. Second, it is squeezing in nature. Okay, Levine is nothing but a cardiologist in US. Okay, so all these people, they have described these things for the first time, so these things are after their name. Huh? So they have made our life difficult because so many MCQ comes on signs only, and they are so difficult names to remember. Yes, so Levine sign, but anyhow we have to remember it. Levine sign, and next is radiating to left arm is another feature. Okay, it radiates to left arm. Next is, it is gradual in onset. When I say gradual in onset, it does not mean that patient will have mild pain for days. No, I don't mean that. When I say gradual in onset means patient's pain starts, let's suppose, in the morning. The most common time to start is early morning. Early morning around 6 a.m. the pain starts. This is classically described in your books. Even Robin says 6 a.m. is the time when the pain starts. Actually, what happens at 6 a.m.? What happens at 6 a.m.? What is the stress in the morning? Do you have any stress in the morning? You are totally fresh. Then why you have MI in the morning? Why cortisol is high? Cortisol is high because of your stress. So from where do you get the stress? Not less steroid. Less steroid is not there. You have more steroid during stress. So from where do you get? Yeah, this Uttarakhand person is right. See, when you get up in the morning, early morning, when you get up, the process of getting up, awaking from the sleep itself is so much stress for the body. See, do you like getting up in the morning? Nobody likes to get up in the morning. Yes or no? We all like to keep sleeping for long time. Huh? So, but we have to get up. When we get up in the morning, so what happens? So that is a major stress on the body and the mind, and that results in increase in cortisol levels. That is why circadian rhythm, you see the cortisol is maximum in the morning. You have a sympathetic drive. That is why you have maximum highest blood pressure is in the morning. So all that is described. Circadian rhythm you can understand by the concept that awakening itself is a stress factor. Okay, so it gradually, what happens, pain starts, but most of the times what happens is that we all are used to this kind of pain. Why? Because we all have gastritis now and then. Every second days we have a gastritis, either we have a stomach problem. So we all feel that, oh, this is some kind of stomach problem that has started. Yes or no? So we all try local therapies, we all try Eno, Pudinara, all these therapies we'll try, and then we'll continue with our activity. But what happens after some time, after half an hour, 1 hour, the pain does not subside with all these measures. Pain keeps on increasing. And gradually it increases to such an intensity that patient cannot tolerate it anymore. Then he comes to hospital. So that means pain is not maximum at its onset. It is gradually increasing. After 1 hour it reaches the maximum, and that is the time when the patient goes to hospital. So gradually in onset, 6 a.m. it is there. And next important points are, is there any tenderness? No tenderness. No tenderness for this chest pain. Okay, there is no tenderness in this chest pain. And see, all the signs will not be there. You are right. So many times you can have silent MIs also. So these symptoms are not, these are classical symptoms. And one thing you always remember is that when we tell you or when we teach you, we teach about ideal things. Okay, so these are the ideal symptoms that the patient can present. And when MCQ comes to you, clinical problems, they are also ideal clinical problems. Okay, so don't worry whether this thing would be there or not. When they ask you question, all these would be there, so that you can make a diagnosis. Okay, so no tenderness is there. So if you have tenderness, that means what? When you are pressing, you are not touching the heart, so you cannot have tenderness. Yes or no? You cannot touch the heart simply by pressing the chest. You can touch the heart emotionally. Yes or no? So no tenderness. If you have tenderness, that is means it is some kind of musculoskeletal disorder, And what is the musculoskeletal disorder that mimics MI? This is which syndrome? Tietz syndrome. Yeah, right. So Tietz syndrome, so if there is tenderness, it rules out ischemia. Next is your no postural variation, no postural variation, no pleuritis. So all these features, if they are present, they rule out ischemia as the cause of MI, as the cause of chest pain. Okay, so these are the features of ischemic chest pain. And now let's talk about differential diagnosis. Before I go on to the management of MI, we will discuss about the differential diagnosis, where we will discuss about pulmonary embolism, aortic dissection, and acute pericarditis. We'll finish these three topics in the differential diagnosis, and then we'll talk about the management of MI finally. Okay, so we'll take a 10 minutes break over here, and we'll reassemble around 6:30, 6:35. Okay, so 6:35 we will reassemble, and we'll continue our class. It already started late, so we can continue. You tell me till what time you want to study. 8 o'clock, 9 o'clock, whatever you tell me, I'll continue till that time. Okay, so majority says 9, few says 8 and 8:30. So we'll try to finish it off 8:30 at 8:45. Okay, so that will be a kind of a balance between 8 and 9. Okay, okay. So we'll take a break for 10 to 15 minutes. And any question you want to ask from the previous topic, you can ask me now, or you can ask me at the end of the break. Rest of you can go ahead with the break. Yes, go ahead. I am here only waiting for your question. If you have any question, you can ask me, or I'll also go for break. See, I told you broad QRS because everything slows down. Everything slows down means conduction velocity through ventricles will also slow down. That will delay, that will prolong the QRS because depolarization is taking more time. Purkinje is most common. What do you mean by most common? I did not understand your question. See, okay, 2 3 questions. I'll just finish off very rapidly. Number one is primary and secondary prophylaxis of stroke in AFib. See, primary prophylaxis, I've told you, in case of valvular heart disease or in non-valvular, depending on the CHAD score. If the patient already has a stroke, then if the patient has atrial fibrillation along with it, you have to give secondary prevention as anticoagulation therapy. If only he has a stroke, no atrial fibrillation, then you can continue with the antiplatelet therapy. Okay, so it depends the etiology. Okay, if it is an emboli, that is etiology, you have to give anticoagulation. If it is an atherosclerotic disease, then even the antiplatelets are enough. And next is your maximum conductive velocity of Purkinje fibers. It is 4 meters per second. See, AV node is 0.1 meters per second, and Purkinje fibers is 4 meters per second. See, for any individual question, any individual thing you want to ask me, you can ask me, you can mail me your question and I'll respond. Over here, stick to the general topics that we are covering. Okay, lone AF you want to discuss, I'll discuss lone AF after the break. No, nothing in Purkinje fibers in bradyarrhythmia. Okay. So you all are welcome to ask me individual questions through your. You can mail me in your to my mail address, and I will answer your questions. Okay. And rest of it, common thing you want to ask me, common thing I'll answer. One thing is loan AFib, I'll discuss it. Okay. I'll take break also. This is my email address. You can ask me whenever you want to. Okay, I'll leave it here. Okay, let's start again the class, right? So, one of you have asked me about low atrial fibrillation. See, low atrial fibrillation is a condition where you have an AFib in a young patient without structural heart disease. So, let me so that means young patient means, when we say young means age less than 60 years with no structural heart disease, and you have an atrial fibrillation, that becomes low atrial fibrillation. And what is classical point about this is that your heart is normal. Your heart is normal, but the cause of atrial fibrillation is something else. So if you treat that cause, your atrial fibrillation will go. You need not treat separately atrial fibrillation. So what is that causes? Most common cause of low atrial fibrillation is, yes, hyperthyroidism. So if you treat hyperthyroidism, there will be no atrial fibrillation again. Second is your another cause of low atrial fibrillation is your holiday heart syndrome. What is holiday heart syndrome? Low AFib causes, number one, hyperthyroidism. Yeah, holiday heart syndrome is after alcohol binge, you have holiday heart syndrome. The most common arrhythmia associated with holiday heart syndrome is another MCQ, atrial fibrillation. And this occurs after binge alcohol intake, and that can result in atrial fibrillation. And if you avoid alcohol, you will not have atrial fibrillation. Okay, so that is how this thing is. So let's move on further. The differential diagnosis of acute chest pain. Where is the buzzer? Okay. Now let's move on further. In WPW, I just forgot to tell you about, there are two types of, see, when we talk about WPW, we have discussed about the management, what is the ECG sign. There are certain few more points regarding WPW you can write down. Number one, that left-sided pathway is the most common pathway, left-sided pathway. most common pathway is the left-sided pathway in WPW. WPW we are talking about. Okay. So we call it as type A. And right-sided pathways are the second most common. So we call them as type B. Another important point is WPW is the only situation where your WPW ECG changes decreases with age. It decreases with age. All arrhythmias, rest all arrhythmias, if you take up AFib, you take up VT, ventricular fibrillation, they all increase with age. Okay, so that is the only situation which decreases with age. I think that is more than enough for WPW. And AFib also we have discussed. Now let's move on to the differential diagnosis of acute chest pain. Differential diagnosis of acute chest pain. When I say the first differential diagnosis is acute pericarditis. Write down acute pericarditis. So see, a patient of chest pain coming to you, left-sided chest pain. Okay, so what is the first investigation that you will do? What is the first investigation you will do? ECG, yeah. So see, after MBBS, if you realize what is the position that you get is after MBBS is a medical officer. You can be posted in a peripheral center or in a tertiary center. You will be as a casualty medical officer. So what is the role of a medical officer? That is very important, and that is what the basis of the MCQs are. The role of a medical officer is to make a diagnosis, provisional diagnosis, so that you can triage the patient to a particular field. Okay, so patient of chest pain comes to you, you make a diagnosis, okay, this is an MI, looking at the ECG, whatever symptoms, and then you refer the patient to cardiologist. You'll give me a call, sir, there is a patient and you have to manage the MI. Okay, I'll come. If you think it is a gastritis, you'll give a call to gastroenterologist. Oh, sir, there is a patient, come and see the patient. Yes or no? So that is the basic. That is the basic for you to have the knowledge that you have to make a diagnosis, provisional diagnosis. That may be wrong. That is not required. That is why we give you all ideal situation that you should recognize and make a diagnosis. Okay. So a patient of chest pain comes to you, you got an ECG done, and I say there is an ST elevation in ECG. This is a very common practical situation I am telling you. Now, what is the diagnosis? Or you want some other test to be done? Yes. You want some other test to be done? Okay, somebody says TROP-T, sir, do the TROP-T. Okay, I do the TROP-T test and that comes out to be positive. Now, what is the diagnosis? So now everybody agrees that it is an MI. Huh? So you will manage the patient, thrombolize the patient, and then you have given the thrombolysis, and then you will refer the patient to me and saying that, sir, for further management, I am sending this patient to you. Okay, so this is not theoretical exercise. See, I commonly see patients like this in CCU. And when I see the patient is not lying down, he is sitting all the time. And he is not that breathless in the sitting position. So when I ask the patient, why you are not lying down? So he tells me, sir, the pain increases on lying down. So that means, what is it? There is a postural variation in the chest pain, yes or no? That increases on lying down. So what do you think is the diagnosis? First of all, it is not ischemic. See, CHF, I told you, patient is not dyspneic at rest. If he is dyspneic at rest, it would have been okay, orthopnea. Then you can say it can be orthopnea. Yes or no? Okay, so that means it is not orthopnea. Patient is not dyspneic at rest. So that means there is something else. His pain increases, not the breathlessness increases. So its pain increases on lying down. So that means there is postural variation in pain that increases on lying down. Another, I ask him whether it increases on taking deep breath. He says yes. So that means it is pleuritic in nature also. So if these two features are present in the chest pain, so that makes only one diagnosis. And what is that diagnosis? That diagnosis is your acute pericarditis. So that diagnosis is acute pericarditis. You have a postural variation, you have pleuritic in nature. So that means you can differentiate acute pericarditis from acute MI. So you can differentiate between acute pericarditis and acute MI on the basis of history. And investigations, if you see your ECG. ECG is ST elevation, which is seen even in your MI. So can we differentiate on the basis of ECG? Let's see. There are certain differences that we can use to differentiate between MI and acute pericarditis, and this comes as an MCQ. So what is the difference between ECG, between acute MI and pericarditis? Let us draw. Let me draw. Make two columns. Yeah, trop T is positive in acute pericarditis. So that is why I say acute pericarditis is a great mimicker. So acute MI, let's talk about acute MI. Draw your page, divide your page, acute pericarditis. Okay, acute MI, when I say, let's suppose patient before chest pain, ECG was absolutely normal, right? So before chest pain, ECG would be normal, right? Now this patient has developed MI. Now what will happen? The earliest change in ischemia is what? Tall T wave. But how it is different from the hyperkalemic T wave? What is the base? Base is broad, not narrow. So this is what is differentiating feature from hyperkalemia. And another important MCQ is that this is the earliest change of ischemia. Earliest change of ischemia. Okay, next point. If you don't treat it, most of the times it is not diagnosed at this stage. The next stage would be what? ST elevation. ST elevation. This kind of ST elevation. How do you diagnose ST elevation? ST is not a point, it is a segment. ST is a line. So which part of the line you take for calculating ST elevation? It is the J point. J point you take. J point is nothing but QRS junction with ST segment. So this is your J point that would be elevated, and this is what you call as ST elevation. Okay, so now this ST is elevated this much. So but what is the characteristics of this ST elevation? Number one point, this ST elevation, it is convex upward, yes or no, or coving upward? Convex or coving upward. Second is convex or coving upward. Second point, it is localized. What do you mean by localized? When I say inferior wall MI, which leads? Which leads would be involved in inferior wall MI? 2, 3 AVF. Yes or no? So that means you will have localized, not V3, V4. Merit is wrong. 2-3 AVF would be your inferior wall MI. So you will not have ST elevation in rest of the leads. It would be 2-3 AVF. Right? So that means it is localized. It is localized to particular territory. If I say lateral wall MI, which leads? 1 AVL, V5, V6. You will have in lateral wall MI. 1 AVL, V5, V6 also. Right? So you will have localized ST elevation, and in rest of the leads what you will see, where you do not have ST elevation, you will find reciprocal ST depression. Yes, you remember that question of ECG I had asked you? 2-3 AVF ST was elevated, but in rest of the ECGs ST was depressed. So that is the reciprocal changes. Okay, fourth point. Okay, that is all about the ST elevation in MI. And now after this what will happen? If let's suppose first year PG in the emergency saw this patient of ST elevation. Now this patient has an ST elevation in ECG. He thinks, oh, let's see what happens to this ECG, whether the changes are the same that Dr. Sandeep told us in the class, or these are the different changes. He want to test it. Okay, he doesn't give any treatment. So after 6 hours to 7 hours, what will happen? This ECG will have changes. What will be the changes? Q wave will become deep, R wave will be small, ST will remain elevated, and T inversion will appear. So what would be the changes within hours, 6 to 7 hours? What would be the changes? Deep Q wave, small R wave, ST elevation, and T inversion. ST will be elevated still, and T inversion would be there. Okay. So now after this, last change after 24 hours, what would be the change after 24 hours? There would be QS complex formed, QS complex formed. ST would settle down, there would be no ST elevation. T inversion will persist. T inversion will persist. Okay, so QS, T inversion, this is how you will discharge the patient with ECG. This ECG you will discharge. This is what is MI changes. So many MCQs we have covered over here. Now next point, acute pericarditis. Okay, before acute pericarditis ECG was normal, just like MI patient. Okay, when he developed acute pericarditis, what happened? ST elevation happened. So what is the ST elevation, type of ST elevation in this? Yes. Can you see the diagram and tell me what is the difference in the ST elevation of the two conditions? See this ST elevation, it is concave upward. Very good. Concave upward. Next, second point. Concave upward. Second point is, it is diffuse. It will be seen in all the ECG leads. Not localized. It is diffuse in nature. Except you may not find it in AVR and V1. May not find it in AVR and V1. Rest in all the leads you will find this. Okay. Third point. No reciprocal changes. Obviously there will be no reciprocal changes. Fourth point. PR segment depression. PR segment depression. PR segment depression. Okay. So now after this, what is the next change that occurs? After days or weeks, after weeks, what will happen? After weeks means 2 weeks, 3 weeks, what will happen? ST will settle down. It will again become a normal ECG. ST settles down, normal ECG. And then after months, what will happen after months? months, T inversion will occur. T inversion will occur. So that means the changes occurs very gradually. Time it takes lot of time for changes to occur. Number 2, ST elevation and T inversion never occur simultaneously. See, in the MI you had ST elevation and T inversion both together in your fourth ECG in MI. Yes or no? Whereas in case of acute pericarditis, your ST first settles down, ECG becomes normal, and then T inversion occurs. So you will never find ST elevation and T inversion together in acute pericarditis. Okay, so this is how you can differentiate on the basis of ECG acute pericarditis versus acute MI. And now, so what should I do with this patient that you have sent to me? Yes, because you have already made a diagnosis of acute MI and you have already thrombolized the patient. See, if I now tell the patient that you made a wrong diagnosis and I send the patient back, what will happen? He will be very unhappy that he underwent all these things just because of the wrong diagnosis that you made, and he will come back and had a fight with you. Yes or no? And whereas, so this is not, that is what I want. I will do the angiography in this patient of acute pericarditis. On angiography, what would be there? Coronaries would be normal. It would be all normal coronaries. So once the coronaries are normal, I'll tell the patient, see, that doctor thrombolized you so well that all your coronaries are normal. Now you don't need any stenting or anything. See, the patient would be so happy. He must be expecting some blockage, and now there is no blockage. He would be so happy. Yes or no? He'll go back. He'll bring sweets to you that you thrombolized him so well. Yes? So you will send me more patients. Yes or no? The practical point. So I will also be happy. So pericarditis is one condition that makes everybody happy. Okay. So that is how we manage acute what is the management of acute pericarditis after going through all this? What is the management that we will give him? The management that we will give him is nothing but NSAIDs. NSAIDs, I'll prescribe him NSAIDs. NSAIDs. That is anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. Okay. NSAIDs. That's it. Right. So nothing much to be in this, nothing to get confused. It is just the gradual changes that happens in the ECG. You should know how to differentiate between the MI and acute pericarditis. Okay. So there is if you are not clear about reciprocal ST changes, just let me show you one of the ECG that I had earlier shown. I'll show you again so that you can understand what is reciprocal changes. One of the ECG that we had already discussed while localizing the MI. Okay. See, can you see the ECG? Your ST is elevated. Where is your ST elevated? ST is elevated in your 2-3 AVR. This is what we discussed. So this is a typical MI ECG. ST is elevated, whereas your reciprocal 1 AVL, AVR, 1, 2, 3, all are negative. ST is depressed. Yes or no? So this is what is reciprocal changes. You will have opposite changes in the opposite direction. So this is what is reciprocal changes, and this will be seen only in case of MI patient. Okay, let's move on further regarding the next differential diagnosis other than the acute pericarditis. What is the next differential diagnosis of acute chest pain? from acute pericarditis. One is acute pericarditis, second would be second differential diagnosis. See, thrombolysis is not given in pericarditis. It is, I gave you an example of wrong diagnosis that you thought to be MI and you thrombolized the patient and sent to me. Okay, so nothing is to be, thrombolysis is not the treatment. That is the wrong treatment that you had given. Okay, so now next differential diagnosis is pulmonary embolism. Let's talk about pulmonary embolism. This is an important topic. Now, when we talk about pulmonary embolism, see, very important is your risk factor. Whenever a MCQ comes, it will show that there are risk factors present. So, what are the risk factors for pulmonary embolism? Number one, any history of DVT or current DVT. If there is a DVT, it is a risk factor. Second, post-trauma bed rest. Post-trauma or surgery. See, surgery in India itself is a trauma, so it's one and the same thing. Trauma or surgery, post-trauma, post-surgery, bed rest patient, bedridden patient. Third, what is the risk factor? Risk factor third is your perimenopausal, peripartum females. Okay, they have a hypercoagulable stage. They have the IVC is compressed by the gravid uterus because of the dextroversion. So your IVC is compressed. There is a stasis of the blood in the legs. There is a hypercoagulable stage. So all that results in DVT. And from DVT you can have pulmonary embolism. Okay, so peripartum females is commonly seen. And the last is your tumors. Which malignancy is associated with thrombus formation? The syndrome is Trousseau syndrome. Which malignancy? Which malignancy causes Trousseau syndrome? Not renal cell carcinoma. Renal cell carcinoma can cause IVC thrombosis. That is a different thing because it penetrates into IVC. Yeah, pancreatic. Gastric also, when it is a mucinous gastric malignancy can also cause this. So pancreatic is the most common. So another is leukemia. Which leukemia causes prothrombotic stage? Any leukemia? Yes. M3, what is the name? AML3, what is the name? Acute promyelocytic leukemia. Okay, acute promyelocytic leukemia, they all causes thrombosis and that may result into your DVT formation. Okay, so that may result in pulmonary embolism. So these four risk factors if are present in the question, so the diagnosis will be directly, what is the diagnosis? Acute pulmonary embolism. Don't have to go anywhere else. Okay, next. Now, with these risk factors, if the patient, what is the presenting symptom? What would be the symptom of this individual? Generally, the patient presents with breathlessness and chest pain. What is the nature of the chest pain? It is pleuritic in nature. Okay, so now these individuals who present with breathlessness, chest pain, sometimes they also have fever along with the chest pain. So what do you think is the differential diagnosis that comes to your mind? Patient comes to you with fever, chest pain, breathlessness. What is the first differential diagnosis that comes to your mind? From pneumonia. Yes, very good. It is the pneumonia that comes to your mind. That patient may have pneumonia also. So what is the differential? How can you differentiate between the two? Between the pneumonia as well as acute pulmonary embolism. So very important differentiating feature is that chest on examination would be normal if it is normal in pulmonary embolism. But in case of pneumonia, you will always have crackles, you will have something on X-ray. You can have bronchial breath sound depending on the stage of pneumonia. What is the stage of pneumonia that you can result in your findings accordingly. Okay, so this becomes an important differential diagnosis. Okay, what are the other clinical signs that are present in this patient? The other clinical signs that would be present would be tachypnea, tachycardia. Patient would be tachypneic, tachycardia would be there, and on investigation, when you do the investigation, what would be there on investigation? On investigation, what would be there? You do the chest X-ray. Any patient who comes with breathlessness, obviously you will do the chest X-ray. So chest X-ray, if it is normal, goes in favor of what? Pulmonary embolism. It rules out pneumonia. But there can be specific signs of pulmonary embolism also present in X-ray. What are the specific pulmonary embolism signs on X-ray? You must have done in your radiology class. What is that? Yes? What is Western mark sign? What is Western mark sign? Yeah, right, absolutely right. Mysore is right. Hampton sign. What is it? Western mark sign is nothing but oligemia. What is oligemia? See, you understand it. There is two pulmonary arteries. Let's suppose these are the two pulmonary arteries. Okay, right and left. If the thrombus goes and blocks the left pulmonary artery, let's suppose this is the right pulmonary artery. If the left is blocked, what will happen? Blood supply to this area would be decreased. Yes or no? So this will appear as, how will it appear as on X-ray? More black or more white? This area will appear on X-ray as more black or more white? Okay, so few are saying black, they are right. See, it would be more black, not white. White, when you see white lines in the X-ray, that is the bronchovascular markings that you see. Air you see is black. So what happens is, when there is no blood in the vessels, these vessels will collapse, so their shadows will decrease. So when their shadow decreases, shadow will increase, so blackness will increase. So you will have more black, not less black or white. Okay, so you have more black, that is focal oligemia. Second is Hampton sign. What happens is, sometimes a very distal infarct can occur. If infarction occurs in the lung, then it will result in opacified wedge shape opacity. This we call as wedge shaped opacity. And wedge shape opacity, and this is what is known as Hampton sign when infarction occurs. Okay, now if you have understood these two signs, these are the signs where the blockage is. Now what will happen to the right pulmonary artery? You tell me. The entire blood, now instead of going into left pulmonary artery, it will go towards the right pulmonary artery. So what do you think will happen to the right pulmonary artery? It will be dilated or what? Yes, it would be dilated. So that means right pulmonary artery becomes dilated, and this dilated shadow that you see on X-ray is known as which sign? This is known as Pala's sign. Okay, so you all know your radiology quite well. Okay, good. So let's move on further. These are the X-ray signs. That can be their melting snow sign, but see, these are the three important signs because they are being given in your Harrison. So whenever they are asked, they are specific for the signs that are given in your Harrison. There can be n number of signs. I generally don't go into details which are not relevant. Okay, so even if you don't remember Fleschner and melting snow sign, just remember these three signs, they are more than enough. Okay, so let's move on further. What are the other things that you can see? You will get an ABG done in this individual. Why? Because breathlessness is there. So you will find that saturation would be low. So what is happening in this individual? You should know the pathophysiology behind this. What is happening in this individual? Your pulmonary artery is blocked, so blood perfusion to this area is blocked. But what is happening to the ventilation to this area? Ventilation to this area is normal or abnormal? Ventilation to this area, left lung, it is normal. So what is resulting in ventilation perfusion mismatch? There is no perfusion but there is a ventilation, so that results in ventilation perfusion mismatch. So this is the basic pathophysiology for your acute pulmonary embolism, ventilation perfusion mismatch. Okay, so that means ventilation perfusion mismatch means what? It means that ventilation is normal but perfusion is reduced. So ventilation is normal means alveolar oxygen. There is another parameter that we should know. Alveolar oxygen. What it will happen to alveolar oxygen? Because ventilation is normal, alveolar oxygen would be normal. But because perfusion is decreased, so arterial oxygen saturation is reduced, decrease. Yes or no? So what will happen to the difference between the two? Difference between the two will increase. Okay, this is a very important parameter that you should always remember. This we call as alveolar arterial oxygen difference. Alveolar arterial oxygen difference. This you will always see whenever there is a ventilation perfusion mismatch. Okay, so any condition resulting in ventilation perfusion mismatch, you will have increased alveolar arterial oxygen difference. This is an important MCQ. Okay, one last point about this pulmonary embolism, and important thing, because from the physiology point of view, what will happen to the CO2? What will happen to CO2? It will increase, it will remain the same, or it will decrease? Okay, so we have different opinions. Many are saying increase, only two are saying decrease, and one is saying same. So see, what is happening is, from your physiology, if you can remember, tell me which is easily diffusible, CO2 or oxygen? Easily diffusible gas is CO2. Nobody has a question about it. Okay, you all say CO2. So see what is happening. This individual has low oxygen in the blood, and because low oxygen is there, so he will hyperventilate. Yes or no? Hyperventilate. His respiratory rate will increase, so he is hyperventilating. So what will happen? CO2 diffusion will not be affected because it is easily diffusible. So now what will happen? Because he is hyperventilating, CO2 diffusion is not affected, so more CO2 would be drained out, resulting in what? Resulting in hypocarbia, washed out CO2. Very good. So it will be washed out. CO2 would be washed out, resulting in decreased CO2. So these individuals, they have decreased CO2. Okay, so always remember, just respiratory already must have been discussed. I'll just tell you one important thing in life. Always remember, when you read an ABG, CO2 never increases in ABG until and unless there are two things. Number one, either patient is not ventilating, that means respiratory arrest, then you will have CO2 increase. Second, when you choke the patient, he is not able to throw the air out, so you have choked the patient, you have closed his nose, closed his mouth, or you have constricted the large airways, trachea or bronchi. That is why COPD, you will have increased CO2. You have increased CO2 whenever you choke the patient. Okay, so that is the only two conditions where you will have increased CO2. Rest all conditions you will have decreased CO2. You have understood? So that is the situation. And or in the end stage of any respiratory disease, when it is so much disease that it ultimately results in CO2 and oxygen both being affected. So that is how the physiology is. So that is about pulmonary embolism. So if they ask you what all changes would be there in the blood, you should know decrease CO2, increase alveolar arterial oxygen difference, decrease saturation of oxygen. Okay, pulse rate, respiratory rate, all would be high. Okay, now let's talk about the investigation of choice for acute pulmonary embolism. What is the investigation of choice? See, there are two investigations. Number one, if you have to make a diagnosis, for investigation of choice for diagnosis is CT pulmonary angiography. Not HRCT, not MDCT, CT pulmonary angiography. HRCT we do not give contrast. It is only that, you know how CT is taken? See, when the CT patient is there in the machine of CT, you have seen the CT machine. CT machine starts cutting the slices of the patient and gives you as a photograph. Each slice is shown as a photograph. Okay, so HR means it will cut more slices of the patient and show you more details. So that is high resolution CT. It does not mean contrast. Okay, whereas contrast CT pulmonary angiography, whenever you have to do angiography, any vessel you have to see, you put a contrast. So this is a contrast CT pulmonary angiography. This is the gold standard. Investigation of choice. Okay, and what is the investigation of choice to rule out pulmonary embolism? To rule out pulmonary embolism, this is D-dimer. Okay, so what are the clinical situations that you do D-dimer? What are the clinical situations you do CT pulmonary angio? See, always remember, if you have high suspicion of patient of pulmonary embolism, you will do CT angio because you have to make a diagnosis. But if you suspect that it is not a pulmonary embolism, then you have to just rule out one of the cause being pulmonary embolism. You have to rule out. So that would be you do the D-dimer, it will rule out the pulmonary embolism. Okay, so this is how we investigate, and they'll directly ask you the question. This will not be put up as a clinical question. Okay, what is the management of acute pulmonary embolism? See, for management, I'll divide the acute pulmonary embolism into three parts. One is massive, submassive, and small. Okay, so over here, divide your page. RV function, RV dysfunction, write down RV dysfunction, write down hypotension, okay, write down anticoagulation therapy, and write down thrombolytic. Okay, so these are the four things. Now let's see, what is massive pulmonary embolism? When I say massive pulmonary embolism, that means patient has RV dysfunction, he is in hypotension. So what is happening? See, pulmonary embolism, I just stress on you should understand the disease, okay, and you should know what is there, because that will solve many of the general questions that you get. Okay, and you should know the important points like what is the investigation of choice, okay, what are the Pala sign, what are these signs, that you should know. Okay, see, we again come back. What happens when suddenly your pulmonary artery gets blocked? Tell me what will happen. Suddenly your pulmonary artery gets blocked. Let's suppose this is the right and this is left pulmonary artery. This gets blocked suddenly. What will happen to the RV? Tell me what will happen to the RV? RV is pumping blood into the pulmonary artery and suddenly your pulmonary artery gets blocked. So that means there is lot of resistance from the pulmonary artery. increase pressure in the pulmonary artery. So what will happen? This RV, what will happen to the RV? It is pumping blood against high pressure. What will happen? Yes, what will happen? What do you think? Hypertrophy. Okay, most of you say hypertrophy. See, what happens? You tell me, if I say tomorrow we have a all India exam, what will happen to all of you? Yes. What will happen to all of you? The moment I say tomorrow is your exam, nobody will pass the exam. Why? Because all of you will fail. The reason being, you did not have enough time. Suddenly the exam came and you were not prepared. Similarly, RV, it's all of a sudden there was a pressure on the RV. It was not prepared for it. So what will happen to RV? It will fail. RV undergoes dilatation. RV fails. Whenever anything fails, it dilates. So RV will fail, RV fails, and it undergoes dilatation. This we call as RV dysfunction, acute right failure, whatever you may call it. Okay, so in heart, or in fact in any organ, if you take, any acute insult will result in its failure. If I say I suddenly increase the systemic pressure, what will happen to the LV? LV will fail. LV will not undergo hypertrophy. And similarly, if I say, okay, if I say pulmonary artery pressure increases gradually, slowly over the next 1 year. So what will happen to RV? RV will gradually undergo hypertrophy. Okay, it will not fail, it will undergo hypertrophy because it has the time to undergo changes. Similarly, if your exam is 1 year down the lane, so now you will plan, okay, I'll join dams, I'll do this, I'll do that. Yes or no? So you will have your hypertrophy. Your brain will hypertrophy. Right? So similarly, you will have your this RV, it will fail in this acute condition. So RV failure will occur only if it is a massive pulmonary embolism. Okay. And now what will happen to the LV? See what is happening. RV is not pumping blood forward. So this blood goes into LV. Now LV is not receiving the blood. So if LV is not receiving the blood, this blood goes from RV to pulmonary artery. If RV is not pumping blood, this blood is not going into LV. So LV is receiving less of preload, decreased preload of LV. Yes or no? Decreased preload of LV means decreased cardiac output, means hypotension. So both of these factors, they are related to each other. LV will not fail, but preload will decrease and hypotension will occur. Okay, so that is RV will fail, not LV. Okay, so now let's talk about our this thing, pathogenesis, how we classify. Okay, massive is when both RV dysfunction and hypotension are present, resulting in both will be present in massive pulmonary embolism. So you will give anticoagulation therapy as well as thrombolytics. Both will be given as the therapy. Okay, now when you call it as submassive pulmonary embolism, submassive pulmonary embolism means RV dysfunction is present but not hypotension. Patient is hemodynamically stable, so you have to give anticoagulation therapy, but thrombolytic therapy is plus minus. Small means no RV dysfunction, no hypotension, anticoagulation therapy has to be given, and no thrombolytic. So that is how the management of pulmonary embolism is. Okay, so simple thing, sudden increase in pulmonary artery pressure puts pressure on the RV fails. RV fails, does not pump blood forward, so LV receives less of blood, that results in decrease in cardiac output of the LV, resulting in hypotension, systemic hypotension. Okay, now when do you give IVC filter? IVC filter, what is the indication for giving IVC filter? What do we mean IVC filter? IVC filter means that you are putting a filter in the IVC so that no blood clot goes from your this thing from your leg to the lungs. Okay, so that means if a patient has recurrent DVT on anticoagulation therapy, recurrent DVT on anticoagulation therapy, you will give what? You will give DVT on anticoagulation therapy, you will give IVC filter. Okay, so that finishes the pulmonary embolism. Let's talk about the third differential diagnosis. What is the third differential diagnosis I am going to talk about? That is contraindication to thrombolysis, not thrombolysis, contraindication to anticoagulation therapy is another indication for IVC filter. Contraindication to anticoagulation therapy. If a patient of DVT comes and you cannot give anticoagulation therapy, then it will be you can give IVC filter. Okay. The next is disease that we are going to see is your acute aortic dissection. Let's see what are the acute aortic dissection. What are the things that we have to see in acute aortic dissection? This is the third differential diagnosis, and then we will move on to your acute aortic dissection. Divide your page into ascending, descending common features. Common features, ascending and descending. Okay. See what happens in aortic dissection. First of all, the classification, that ascending and descending, this is given in your Robbins, so I'll just revise you first. First is your Stanford classification, must have been done in your pathology. Stanford. This divided into type A and type B type of aortic dissection. Type A means starting from ascending aorta, and type B means starting from descending aorta. Okay. Now, D. Becky was another surgeon. He was a very famous surgeon. D. Becky. He further gave the classification for aortic dissection, again given in your Robbins and comes as an MCQ. Type 1, type 2 and type 3. Okay. Type 1 and type 2. What is type 1 and type 2? See, type 1 and type 2 means, I'll draw the diagram and explain you. This is the aorta that you know, this is the aorta, how it is. Okay. So if this is the aorta that you know, what happens is, because it is a type A, it has to start in ascending aorta. So starting from ascending aorta, if it continues into descending also, dissection, this is known as type 1. Type 2 is starting in ascending, remaining within the ascending. Type 3, starting in descending, going into descending, not involving ascending at all. So these are the three types according to D. Becky classification. Okay, so these are the three types of classification. Very simple. Okay, now let's talk about the risk factors. Risk factors for aortic dissection. Risk factor number 1. Whenever there is an ascending aortic dissection, generally the presentation is young male with connective tissue disorders. Connective tissue disorder, like, for example, what is the most common connective tissue disorder? Marfan syndrome, absolutely right. So you have a Marfan syndrome. So they will not give Marfan syndrome directly. They will give a 32-year-old male with long fingers, with hypermobile joints or high arch palate, presented with sudden onset acute chest pain. So what is the diagnosis? Diagnosis is acute aortic dissection, nothing else. Acute aortic dissection. Okay, next. Another is your descending aortic dissection affects old individuals with atherosclerotic risk factors. All atherosclerotic risk factor. He'll be diabetic, hypertensive, smoker, 65-year-old male presenting with pain. Okay, so that becomes a classical history for descending aortic dissection. Now, important point. Why the atherosclerotic risk factors, they result in descending aortic dissection? So you must have done in your atherosclerotic chapter which part of the heart or aorta is most commonly affected by atherosclerosis. Which is the most commonly part affected? Abdominal aorta, that is abdominal descending aorta, right? So that is why atherosclerotic individuals, they have this aorta involved, and this results into dissection. Okay, it can be infra-suprarenal. You have more common infrarenal, but that is further classification. Okay, so let's talk about say infrarenal, suprarenal. That is more about aortic aneurysm, not dissection. So please do not get confused with that. Okay, so let's move on to the next point. This is the risk factors we have been talking about. Next is your clinical presentation. What is the clinical presentation in these individuals? Okay, the clinical presentation would be in ascending aorta, where would you think the chest pain would be? Retrosternal chest pain. The patient presents with retrosternal chest pain. And whereas in case of descending aorta, where do you think the pain would be? Yes, descending aorta. It's not descending aorta will not be retrosternal. It goes posteriorly. See, the aorta starts from the anterior part of the precordium, goes behind, and then descends in the back. So descending aorta is almost in the back. So you will have back pain. Absolutely right. And radiation. Retrosternal chest pain, see the arch, it will radiate along with the arch, so it radiates back, radiates towards back. Whereas back pain, it will radiate downward. Interscapular area, wherever you find this term interscapular area, the diagnosis is one and only diagnosis. What is that? Aortic dissection. See, these terms are so classical terms that when they are coming in the question, don't read the question complete, just mark the answer aortic dissection. 99% of the times you will be right. Okay, so next point. What is the pain characteristics? Pain character. This will be same in both, that is, it is stabbing in nature, stabbing, tearing. If these terms are used in the question, that itself means, what is it? Ascending or descending aortic dissection. It has to be aortic dissection. Stabbing, tearing in nature. Okay, and as compared to MI, we discussed MI that it gradually onset, whereas in this, it is maximum at its onset. Maximum at its onset. It is maximum at its onset. Pain is maximum at its onset. Okay, so these terms are very, very classic for aortic dissection. If these are there, that means you are dealing with aortic dissection. Okay, let's move on further. Now, what are the complications or clinical signs that you will find in these individuals? So, before I go on to the Next, I'll just okay, let me show you. Again, I divide into ascending and descending, ascending and descending. Okay, let me draw an aorta. See what happens in aorta. This is a enlarged view of ascending aorta I am drawing. Okay, what are the three layers of aortic wall? What are the three layers of aortic wall? Three layers are starting from, this is the one intima, then you have a media, and then you have an adventitia. Okay, so intima, media and adventitia, absolutely right. So what happens is, see, when the dissection occurs, the blood goes and hits the intima. Okay, it causes the stabbing type of thing, and then it starts to flow within the media like this. Okay, so this is how dissection has occurred. So now what will happen? This area wall will become like this. This wall will become like this to adjust the blood. So blood is flowing in the wall. Okay, so you have understood. Now, aorta is a big it is a big vessel. It is a big vessel, right? This dissection will not cause aortic narrowing. Understood? But if any branch is arising from the aorta, let's suppose there was a branch that arises from the aorta. Let's suppose this is the wall of the branch, and this is the wall of the branch. Okay, if this is the wall of the branch and this is the branch that is arising from the aorta, what will happen? This dissection will progress into this branch. Yes or no? Once it progresses into this branch, this wall will get dilated like this. Yes or no? The moment this wall gets dilated like this, what will happen to the blood supply over here? What will happen to the blood supply? The blood supply decreases. So the point is, whenever this dissection extends into your any branch, it will result in decreased blood supply of that branch. Right? So let's see what are the branches that arises and what are the complications that we will see. Okay, the first branch from ascending aorta. What is the first branch, first vessel to arise from ascending aorta? What is the first vessel? Yes, tell me. See, not branch is dilated, it is your wall that is dilated. That will result in narrowing of the branch. Okay, so coronary artery is the first branch that starts. So let's suppose this is your coronary artery. So first artery to be affected is your coronary artery. So in ascending aortic dissection, if coronary artery is involved, that will result in what? ST elevation MI. So MI itself is a complication of aortic dissection. Okay. So which coronary artery is most commonly involved? This is an MCQ. RCA. Right coronary artery is most commonly involved. No, not LAD, RCA. Okay. So I'll just tell you, just remember it. We'll again revise it in the MI chapter, that inferior wall MI is the MI that is caused by RCA occlusion. Inferior wall MI. Okay, so which leads you will have ST elevation? Yes, 2, 3 AVF. Okay, so RCA is the first branch to be affected, resulting into your inferior wall MI. Okay, next branch. Which is the another branch that can be affected? Next branch is your right brachiocephalic artery. So right brachiocephalic artery is the next branch that would be affected. If right brachiocephalic artery is involved, so what will happen to your right radial pulse? Right radial pulse decreases. Okay, whereas left radial pulse, what it would be? Normal. So there would be pulse discrepancy. Pulse discrepancy. This we call as pulse discrepancy. Okay, So that means you will have pulse discrepancy, and all these both complications will you see in descending aortic dissection? Just tell me common sense. No, absolutely right. You will not see in case of your descending aortic dissection, because these branches are not there. Okay. So another important complication that you will see only in ascending aortic dissection is the first to begin with. See, aorta starts from aortic valve, yes or no? Okay. So what happens if your this part of the aortic valve is affected, from where the valve is aortic valve is connected, where the aortic valve is attached, that part of aortic valve is involved. So what will happen to the valve? The valve, it will become incompetent. Valve will become incompetent, resulting in regurgitation. So aortic regurgitation. So acute aortic regurgitation is a feature of ascending aortic dissection. What is the murmur in aortic regurgitation? Which murmur is there in aortic regurgitation? Yes. Okay. Any other choice? Diastolic. Okay, so this is a diastolic murmur, not Austin Flint. Austin Flint murmur you see in AR, definitely Austin Flint murmur, no doubt about it. But see, that is not the primary murmur, that is a secondary murmur. Primary murmur is your first answer is absolutely right. Hubli is absolutely right. Early diastolic murmur. So the early diastolic murmur is the, if new onset early diastolic murmur, if you, it's written in the question with acute chest pain, always it is aortic dissection. You never have AR in MI. You never can have AR in MI. No AR in MI. This was a MCQ asked. No AR in MI. Okay. So MI can never cause AR. Okay, so these are the three complications that you will see only in ascending aortic dissection, never in descending aortic dissection. Let's move on further. The last complication is rupture. Aortic dissection can rupture. How can it rupture? See what will happen. I described you this diagram. There is a blood over here, yes or no? Okay, if the pressure is too much high, then it can rupture outside. Yes. So if this wall ruptures, this will result in rupture of aortic dissection, and that can happen with both ascending and descending. So what will happen if it ruptures into pericardium? It will result in what? Pericardial tamponade. It will result in pericardial tamponade. If it ruptures in pleura, it will cause hemothorax. Okay, so in all these conditions, patient will suddenly will become hypotensive, unstable. Okay, so that is all about the complications of aortic dissection. Let's go on to the investigation. The investigation of choice for aortic dissection. What is the investigation of choice? Absolutely right. But it's not that simple. See, if the patient is unstable patient, investigation is Okay, let me take a new page. If a patient is unstable, investigation is transesophageal echocardiography. If the patient is stable, then MR angiography is the investigation of choice. Okay, MR angiography is the investigation of choice if patient is stable. Okay, so now another point. What is the management? Management depends whether it is type A or type B. Let's talk about type A, type B. That means ascending and descending again. What is the management? All type A, we divide into acute or chronic, acute means less than 2 weeks onset. Chronic means more than 2 weeks onset. Okay. So we divide aortic dissection into two types, acute and chronic, less than 2 weeks, more than 2 weeks. Okay. All type A needs surgery. All acute type A needs surgery. All acute type A needs surgery. Whereas chronic, you do medical management. Type B. Type B, whether acute or chronic, all will be medical management. Whether acute or chronic, all medical management. Okay. Next. The last point, okay, within this exception is, because this is common in Marfan syndrome, we should do the exception. Exception is Marfan syndrome, where you always go for surgery, whatever type it may be. Type A or type B, whatever it is, you do surgery only, surgery. Marfan syndrome, always surgery. Okay, that is an exception. And last point is, what is the medical management? This patient has high blood pressure. How will you bring down the blood pressure? Drug of choice to bring down the blood pressure. IV esmolol is the drug of choice to bring down the blood pressure. No, not labetalol, not nitroprusside. IV esmolol. Esmolol is a shortest acting beta blocker. You have to give beta blocker. Labetalol is not a short acting beta blocker, because this is a hemodynamically, situation is very dynamic. You don't know when the patient will become unstable. So you cannot give labetalol, which is a long acting. The T-half of labetalol is 4 to 6 hours. You cannot give it. Esmolol, the T-half is 30 minutes, 20 to 30 minutes. So you have to give esmolol as the treatment of choice. Okay, this comes as an MCQ also. So from here, we have done all the three differential diagnoses of acute chest pain. Any confusion in all these three topics? I'll move on further after this. Any confusion? Okay, I take the point that there is no confusion. Okay, good. So let's move on further. Very, very important topic from your MCQ point of view. Okay, significant ST elevation, I'll tell you when we talk about MI. Diagnosis of MI, I'll tell you about it. Okay, so see, syphilis affects your ascending aorta. Nowadays it's not common, so I don't talk about syphilis. You can have mycotic aneurysms, you can have syphilitic aneurysm, and that is what is resulting into your, it can result in dissection also. Okay, so if somebody asks you which is the site of most common aortic dissection, the commonest site is your ascending aorta. As far as your pathology Robbins is concerned. So I'll go by your basic books, because MCQ when it comes from your basic books. So aortic dissection most common in ascending aorta. Okay, so then next point is your okay. I think that is all about the medical management. Only is esmolol, you have to control the beta blocker. In some of the studies, I don't want to go into details. Actually, in Marfan syndrome, it has been found that if you give ACE inhibitor, it prevents the progression of the disease of the aorta. That means aorta, if it is weak, let's suppose in Marfan syndrome, if it is dilated, we consider it to be weak if it is dilated. So we start with ACE inhibitor, and it has been found that ACE inhibitor reduces the incidence of aortic dissection. So that is all about prophylactic management. But as far as medical management in an acute condition is concerned, it's all supportive. Rest, only thing that comes as your MCQ is that what is the management of blood pressure drug of choice? Esmolol is the drug of choice. Okay. And small massive and submassive, it can be differentiated on the basis of your CT angiography, how much of your pulmonary arteries are involved. Okay, there are different criterias. I don't want to go into details. You just need to manage. You should know what is the management of what type of it is, because it is given in your Harrison. It just mentions about the small, submassive and massive. Okay, definitions are different, no doubt. There is a definition. Okay, okay. Let's move on further to the management of your that is your ischemic chest pain. Let's see what is ischemic chest pain. Last differential, but last but not the least, is the ischemic chest pain that we will discuss about it. Okay, so let's talk about ischemic chest pain. We have already made a diagnosis that this, okay, on the basis of history, you know that this patient has a chest pain which is ischemic in nature. Okay, so we call it as acute coronary syndrome. Acute coronary syndrome. Okay, so see, from your pathology, if you have read your atherosclerosis chapter and your MI chapter, it's very beautifully given. See, what happens is, what is atherosclerosis? Let me ask you one thing. What is atherosclerosis? It affects which layer of the artery? Intima, media, adventitia, all three. So you have different answers. The right answer is your intima. Okay, it affects your intima. Okay, so intima is the part of your vessel that is affected by atherosclerosis. And see, it is a chronic, it is also known as a chronic inflammatory process. Chronic inflammatory process. Okay, and it starts in one of your in Robbins, it is written it starts even at the age of 13 years, your atherosclerotic process. So if you do autopsy in any age group, you will find some atherosclerosis present. Okay, so what happens is, this atherosclerosis, it can gradually progress, resulting in a blockage of significant part of the artery, and can present as a chronic stable angina. As a chronic stable angina. Or it can present like, if there is an atherosclerotic plaque, even if it is a small plaque, if it ruptures, suddenly it ruptures, resulting in what formation? Thrombus formation. It will result in thrombus formation. This would be an acute presentation. So this will result in the presentation of acute coronary syndrome. So these are the two basic presentations of atherosclerosis. You have understood? So now I am discussing about the acute coronary syndrome first, that is the acute onset chest pain. Okay, so before I go on to the acute onset chest pain, what are the features of unstable plaque? These are given in your Robbins, unstable plaque. So I am covering it because this comes as an MCQ. Whatever is given in your basic sciences is the most important thing. They may not open the Harrison, but they will always look for questions from your basic sciences. Okay, so for unstable plaque, what are the characters of unstable plaque? Which plaque will rupture and result in thrombus formation? This is very, very important. Yes, any guess? So what happens is, you have a plaque. I am drawing the diagram of a plaque. Soft is not an answer. You have to tell me why it is soft. So you have a fibrous cap. Fibrous cap is there, and there is a core in between. Core and fibrous cap. Okay, so now fibrous cap helps in preventing this core from getting exposed. So if you have a thin fibrous cap, that is unstable. Thin fibrous cap, unstable. Number 2, large core, large fatty core. Number 3, fatty, cholesterol, it's all same. Number 3, what else is there inside the core except for fat? Other than the fat, what is there? You have smooth muscle cells. Smooth muscle cells. if they are reduced, decrease smooth muscle cells, decrease. Okay, macrophages or foam cells, they are one and the same thing. Macrophages, increased macrophages. So these four things comprise your unstable plaque. And what happens when the macrophages are there? What will happen? They secrete what is known as MMPs. What are MMPs? These are metalloproteinases. Matrix metalloproteinases. These are proteinases. So what will happen is they will break down the collagen. These collagen will be broken down, resulting in thin fibrous cap. Fibrous matrix metalloproteinases, absolutely right. So that will break down the collagen and reduce the fibrous cap. Okay, so they can say increased MMPs is also a feature of unstable plaque. So these all are the features of unstable plaque. This is an MCQ that comes. Okay, let's move on further. The presentation. Presentation, I have told you it is an acute presentation. Let's see what happens with this acute presentation. See what will happen. You have a artery, you have a plaque, and it suddenly ruptures, resulting into the thrombus formation. Oh, sorry, I'll change the page. Okay, so you have an artery with the plaque that ruptured and resulting into the thrombus formation, and this results in acute coronary syndrome, that is ischemic chest pain. Okay, now what can happen is there are two ways that body can respond to it. Body will try to break down this thrombus. Body will try to break down this thrombus. Yes or no? Okay, you have a plasminogen in your body that will try to break down this thing. Okay, so what will happen? Either the body is successful. If it is successful, it is able to break down, let's suppose, part of the thrombus. If part of the thrombus is broken down, so what will happen? Blood supply will be restored. Yes or no? So what will happen to the chest pain? Chest pain will settle down. Why? Because ischemia settles down. Ischemia settles down. No ischemia now. Okay. Even if it is partly open, it is sufficient to maintain the survival of the cells. So there will be no ischemia. So what will happen is, initially when it is completely occluded, ST would be elevated. But suddenly what will happen, because of the opening of the artery, there will be no ST elevation in the ECG. Okay, second group. Let's talk about the second group simultaneously. Okay, this is important from the management perspective. Okay, now another group. What happened in another group? Our body is not able to break down the thrombus, Thrombus persists like this. So that means ischemia is there. What would be there in the ECG then? What would be there in the ECG? ST elevation. Okay, so you see the difference. Here the thrombus is broken down, though partially, whereas what is happening over here? Thrombus is not being broken down by the body. So what will happen? For ST elevation, you have to break the thrombus from outside. You have to help the patient's body to break the thrombus. So doctor has to help. Whereas in this case, there is no already body has broken down, flow has restored, so you only have to help the body so that the thrombus again does not form. Okay, it doesn't have to break down the thrombus. You don't have to break down the thrombus. Body is breaking down the thrombus. You only have to help that it does not form again. So how can you help in preventing it forming again? How can you prevent it formation again? By giving anticoagulation therapy. Antiplatelets, right, but anticoagulation is more important. So anticoagulation is the mainstay of treatment when there is no ST elevation. And if there is an ST elevation present, that means you have to do revascularization. And revascularization means, how can you do revascularization? There are two ways of doing revascularization, either by PCI or by thrombolysis. PCI or thrombolysis. Okay, so the point is, the basic difference in the management is, because you have to do revascularization in ST elevation and no revascularization acutely. Acutely, I am telling you, when the patient comes to you immediately you will not do anything, start anticoagulation therapy only. So let's finish off the management of no ST elevation, and then we'll come to ST elevation, and then we'll finish it off this topic. Okay, so what is the further management? What is the further management? You have started anticoagulation therapy. Now, after 1 day, or let's suppose the patient came to me today, in the night, patient came. Okay, patient came with no ST elevation, MI. So what I will do is, what is the next step is, I won't do PCI, I won't give thrombolytic immediately. I'll start anticoagulation therapy, and the next day, I'll do angiography. And see whether thrombus is there or not. If the whole thrombus is broken down by the body, there is no thrombus, I will discharge the patient. If there is a thrombus present, then I will do the PCI. Understood? This is very basic difference. That means next day I'll do PCI. If on angiography still there is a thrombus present, you cannot discharge the patient on thrombus. So you have to do the PCI. What is PCI? Percutaneous. What is PCI? Yes. Percutaneous coronary intervention. Okay. So how do we do PCI? Let me see how do we do PCI. See, I'll come to this example again. This is your thrombus. How do we do PCI in an acute setting? Let's suppose on day 2 in non-ST elevation MI, I find this much thrombus on angiography. So what I will do is, I'll pass my wire across this, take a balloon on the wire, inflate the balloon. This balloon will break down this thrombus. Okay, once this thrombus is broken down, it will go, small particles will go forward and blood will be restored. This is how we do PCI. Okay, so that is what is PCI. And so this PCI that we do in case of non-ST elevation MI, this we call as early PCI. Early PCI. Early PCI. Okay. So to do the PCI, you will go through femoral artery, not through the vein. From femoral artery or radial artery, you go to aorta to coronary artery, and coronary artery you do the PCI. Okay. So this is how you manage no ST elevation MI, non-ST elevation MI. Okay. Obviously, Schlesinger it is a Schlesinger technique that used to be, it is a modified Schlesinger technique that we call it. It's not the original Schlesinger technique that he described. So Schlesinger was a interventionist to describe this. Okay, let's talk about further. This PCI and ST elevation, what is the management of ST elevation MI? Let's go on to further. Now in ST elevation MI, see the artery is not open, so you have to open the artery. So that means you will call the cardiologist and ask him to open the artery. So now ST elevation MI management. See the guidelines for ST elevation MI management, it came in 2013 January. So very recent, last year only, and I think your books are older editions. They don't have the updates of these guidelines. So some of the points may not be given in your books, even in your Harrison. Okay, so let's talk about it. See, in the STEMI guideline, whenever I say STEMI guide, ST elevation MI management, the 2-3 important points that you have to remember always is, number one, you have to open the artery as early as possible. As early as possible. Open the artery. Because if you delay, what will happen? That myocardium will die. Then what will happen? Then even if you open the artery, once the myocardium is dead, there is no use of opening the artery. Okay, so one thing is you have to do it as early as possible. Second thing that you have to do is that PCI is always preferred over thrombolytic. PCI is always preferred over thrombolytics. Okay, so that means these are the two basic points that you have to understand before we go on to the management. And obviously one third more point I'll tell you, we'll classify all patients with less than 12-hour onset, more than 12-hour onset. Why this 12 hours cutoff, 12-hour cutoff? That is because after 12 hours, what happens is that thrombus becomes very hard. Thrombus becomes hard. And thrombolytic cannot break it down. Thrombolytic cannot break it. Cannot break it. So that means thrombolytics are contraindicated after 12 hours. Contraindicated after 12 hours. Okay. And next, fourth point. These are the general points I am telling you on which the guidelines are based. So, and after 12 hours, or after in fact after 12 to 20, after 24 hours or 12 to 24 hours, what happens is myocardium is already dead. Myocardium is dead. After 12 hours, myocardium is dead. So, not in all patients you will open the artery. Not in all patients you will do revascularization. Not in all patients you do PCI. Okay. So, let's talk about the management. With these 4 points in your mind, let us talk about STEMI management. Okay, what is the STEMI management? See, the latest guidelines, they say that a patient of ST elevation MI may start of pain. So STEMI guideline means that a patient may present in a peripheral center. What do you mean by peripheral center? Peripheral center means where PCI facilities are not available. PCI facility not available. Okay, so this becomes more important at your level. You will be posted as a medical officer in a peripheral center and patient of ST elevation MI comes to you. So how do you classify? How do you manage this patient? You will see the onset of chest pain, whether it is less than 12 hours or more than 12 hours. If it is less than 12 hours, now you have to do the revascularization. So what is the option with you? to do the revascularization. How can you do revascularization? What are the options with you? Options are either you refer the patient, okay, or you give thrombolysis. Okay, so when to refer for higher center and when to thrombolize? Huh? There is a objective criteria. It cannot be like if you are in a mood, you refer. If you are not in mood, you give thrombolysis. This is not the subjective condition. You have to have objective criteria. Objective criteria is that if you refer the patient and you can get the PCI done in a referral center within 2 hours, in less than 2 hours. Less than 2 hours you can get a PCI done, then you refer the patient. If it will take more than 2 hours for PCI, then what you do? You thrombolize the patient. Okay, very simple. After thrombolysis, what is the next step you have to do? Thrombolysis, after thrombolysis, you have to refer the patient again. Refer. This kind of referral after thrombolysis, this is known as pharma. You have given thrombolytic co-invasive therapy. After thrombolytic, you are referring the patient for PCI. So this becomes both pharma co-invasive therapy. This is the latest term used in the latest guidelines. Okay. So this becomes the highlight point. Those who are going for exam this year, just keep in mind what is pharmacoinvasive therapy. It is a thrombolytics you have given in the peripheral center followed by routine PCI. Followed by PCI. Okay. Now, let's move on further. What are these? What will happen to the individuals who have presented to you after 12 hours? Now after 12 hours, see, you have no other option. You cannot thrombolize these patients. Why? Because it's already contraindicated after 12 hours. So the only thing you have to do is either you do the PCI or you refer the patient. So PCI also you have to refer. So you have nothing to do. You have to refer the patient. Okay. After 12 hours means obviously time 12 hours means from the onset of chest pain. That means chest pain duration is more than 12 hours. Okay. So now what will happen? More than 12 hours you just refer the patient. Okay. Now let's come to the tertiary center where you have referred the patient or patient has directly come to a tertiary center. Okay. There again the patient will come to you. You are a casualty medical officer, CMO we call it. Yes or no? You must have heard of it, CMO in your hospitals. Okay. So now CMO, he again classifies less than 12 hours or more than 12 hours. Okay. Now again less than 12 hours you can do either PCI or you can do thrombolysis. So what are the conditions? When will you do PCI? When will you do thrombolysis? PCI, you will prefer PCI always. So let's suppose you give me a call. Sir, there is a patient of MI. We want to do the PCI. So you kindly take the patient towards your side. Do the PCI. But I say I am busy doing pacemaker. I am putting a pacemaker in a patient. So that will take time, more than 2 hours. So how long you will wait? Is there any fixed criteria to wait, or it depends on your mood? So there is a fixed criteria to wait for whether to wait or not to wait. If there is no, not 2 hours, that is only for the peripheral center. In the tertiary center, you have to thrombolize the patient. You have to do the PCI within 90 minutes. Yes, absolutely right. 90 minutes. So that means 90 minutes means door to balloon time. Balloon that I told you in PCI, while doing PCI, I told you we inflate the balloon and blood perfusion is maintained. So same door to balloon time. Door means entry into the emergency room to balloon time should be less than 90 minutes. If I'm saying it takes me 2 hours, that means more than 90 minutes. Now you will thrombolize the patient. There is a time limit for thrombolysis also. You just cannot, okay, you have told the sister, okay, do the thrombolysis, sister has forgotten, gone for lunch. This cannot work. Door to needle time should be less than 30 minutes. So that means all patients you have to thrombolize within 30 minutes. Okay, so these timings are important. Next, if the patient comes to you after 12 hours, let's suppose the patient comes to you after 12 hours, what will happen? If patient comes to you after 12 hours, see, I told you after 12 hours, what can happen is whole of your myocardium may be dead. There may be no myocardium alive. So what is the fun in opening the artery? Okay, so what is the fun in opening the artery? See, so that means there is no point in doing revascularization in a patient whose myocardium is already dead. Yes or no? So how can you find out whether the myocardium is dead or not? You cannot find out immediately. So you will go by symptoms. If myocardium is dead, will there be any chest pain? Will there be any chest pain if the myocardium is dead? There will be no chest pain. So that means if there is no chest pain, if the patient is stable, so there will be medical management. But if patient complains of chest pain, that means that is suggestive of ischemia, yes or no? So that means there would be some kind of patient is having some alive myocardium or patient is unstable. In both conditions, you will do revascularization. And after 12 hours, what is the only way of doing revascularization? After 12 hours, what is the only way of doing revascularization? Thrombolytics is already contraindicated. So you only have PCI to be done. So you will go for PCI. Okay. So the management of MI, I'll just describe you once again. Very, very easy I have made it. So it should be very clear what is to be answered in the MCQ. Okay. There should be no ambiguity. Okay. See, if it is less than 12 hours, you can do PCI or thrombolysis. PCI is always preferred, but there is a limit. That door to balloon time should be less than 90 minutes. If it is more than 90 minutes, let's suppose cath lab is busy, you go ahead with thrombolysis. Thrombolysis cannot be delayed by more than 30 minutes. Within 30 minutes, once you have decided you have to do the thrombolysis, then door to needle time should be less than 30 minutes. Okay, so door to needle time should be less than 30 minutes. So door to needle time should be less than 30 minutes. Okay, now if the patient comes to you after 12 hours, obviously no chest pain, stable patient, medical management. Chest pain, unstable, do PCI. Okay. Now let's talk about further. See, there was a term I introduced that was a pharmacoinvasive therapy. You have understood what is pharmacoinvasive therapy. So now let's talk about other thing. There is a term known as primary PCI. What is primary PCI? See, when we do PCI directly, that means, what does that mean? That means patient had come to you within 12 hours and you had referred the patient for PCI and I did the PCI within 2 hours, that becomes a primary PCI. Or patient came directly to me, I did the PCI within the 90 minutes, so that becomes a primary PCI. So the term is primary PCI. Now there are two terms more that are no longer done. What are these two terms? Rescue PCI. there is something known as rescue. I'll write down below pharmacoinvasive therapy. This is rescue PCI. What is this rescue PCI? See, rescue PCI used to be done earlier. What was the approach? If thrombolysis you have done in the peripheral center, after thrombolysis, nowadays you send all the patients for PCI. Okay, this is known as pharmacoinvasive therapy. But earlier days, we only used to send patients for PCI where thrombolysis was unsuccessful. So what is the definition of rescue PCI? Rescue PCI is PCI done after thrombolysis, after unsuccessful thrombolysis. So rescue PCI is PCI done after unsuccessful thrombolysis. Okay, and this is not preferred nowadays. Okay, so that finishes the immediate management of ST elevation MI. Any confusion? Any confusion in the management of MI? Okay, there is see, don't ask me why. There can be why for many reasons. If time does not allow me to give answer to all whys, why, I'll just simply tell you, because the bleeding risk is high. Okay, so in acute condition, role of CABG is controversial. You do not go for CABG in acute condition. Okay, that is a controversial. Benefit is there or not until unless there is a complication. We'll talk about the complications tomorrow, and that itself is a long topic. Because it's very, very important. See, these things are important. These things are, to understand these things are important. Why? Because when the question comes, it will not be just a repeat question coming from your MCQ book. It can be new question that they will just change the terminology here and there and form a new question. If you know the concept, you'll be able to answer it. So my purpose of teaching you here is just not to give you the notes and just not tell you the facts. Facts you can get even from your MCQ book. But my point is to make you understand the basics of cardiology. If your cardiology, if you understand it, you will be able to understand the facts also. Okay, so I think I'll end my class for today here. Okay, and some few questions I'll just take up now. They are telling me what. Okay, first of all, those who want to leave, they can leave. I can tell you that tomorrow, what time you want to start the class? It's your choice. I can start whenever you want. Let's see the majority. Okay, so majority says 9, few says 10, only one says 8. Huh? So 8 is out of question. I don't want you to have MI, and neither I want to have MI by having a stress at 8 o'clock. So we'll start at 9 looks like an average time. So 9:15 we will start. Make sure you are there in the class, because I won't repeat if you miss the class. This way we are not able to finish our topics. So I'll start at 9. Okay, now I can take the any question you have. 9 o'clock I'll start. You have few questions. Number one I'll take up is you said that thrombolysis, why thrombolysis is not given in non-ST elevation MI. This itself is clear. I told you. See, artery is already open. Why you want to do the thrombolysis now? Your body is working to break down the thrombus. So if you give a thrombolytic which is not required, it will only add to complications of bleeding and all that. It is not required. You just give anticoagulation therapy. Okay. See, that is just to, there are so many of you are asking me to tell you about VT versus SVT, VT versus SVT. I'll give you the concept tomorrow in the end of your complete cardiology. Okay, because I generally give the concept early in the lecture, but because this is something which is audio visual, you cannot see, I cannot be there right in front of you. You cannot see me completely. So it becomes difficult to describe few things. That is why in the beginning of the class, I think few of you did not understand some things. But never mind. I'll try to explain you tomorrow. Okay, with VT versus SVT. And next of the thing is that anything else you want in the when angioplasty. Retrosternal and substernal, there is not much difference. Okay, retrosternal itself, retrosternal is behind the sternal and sub says substernal, so it's almost the same thing. Okay, but some may use substernal is not a right term. Substernal can be epigastric also. Okay, below sternum. Below sternum you don't know, posterior or inferior. Okay. PCI within 90 minutes means because all these timings that they have given, these timings are to so that you do not delay the procedure. If you delay the procedure, your myocardium is dying. You have to save the myocardium. Why these time limits are? To keep you remind that the time is important. Okay. See, whatever thrombolysis is you have done, after thrombolysis nowadays you are doing PCI routinely. So there is no question of successful or unsuccessful now. Okay. So medical management we will do tomorrow, and ECG changes in acute MI, I think you can ask your batchmates or friends who has drawn it. Okay. So I think that is enough. VT versus SVT I'll take up tomorrow, and rest of the topics will be covered in this MI part tomorrow. Okay. Okay. Thank you then. Thank you everybody. Let's meet tomorrow around 9:30. Okay. See, whatever is left will be covered up tomorrow. So don't push the button. Management is still not over of MI. We'll discuss tomorrow. Okay. Okay. Thank you.